Okay. That's right. Sahasra. Sorry, is also making nominated because always whenever I go to the Cochlear implantation, but also in my hospital also, I'm feeling bored. I did more than 500 cases. I always give a call of anyone I will hearing surgery to observe the surgery. Why? Because my intent is they're all sponsored by the government, and the people's money. It should not be wasted. The knowledge has passed to the other persons wherever required. Till now, 18 surgeons are completed in my country in my hospital. Like that, here also, we have had 8 surgeries yesterday and today, but unfortunately, because of various reasons, no surgeries can be. We are able to do surgeries today with the both techniques. Okay. Okay. Here, already mentioned that before invention of paper and pen, the even knowledge has passed through the hearing only. The Vedas and all, through chanting only they learn. It was known to our ancient people and also mentioned in our mythology and epics also. In Bhagavata, Mahabharata, Prahlada learned about Vishnu through Narada when he was in his mother womb. Like that, the second issue in Mahabharata, Abhimanyu learned Padmavyuha, see the shape of country. Padmavyuha also from Sri Krishna when he was in mother womb. That means our people knows and also nature knows. We have become a superior in the animal kingdom by way of listening. Through listening, we develop the speech and then language. It makes the entire globe into a small village because of the communication only. Communication only develops through listening. That's why the special sense functioning before birth. That is the importance of hearing. సర్వేంద్రియాణం నయనం ప్రధానం నయనంతో పాటు శ్రవణము ప్రధానమే మనం అనుకోవాలి విషయం ఇంకొక మేజర్ అడ్వాన్స్ సైన్స్ ఈస్ invention of the cochlear implant. Out of 5 special senses, we are able to restore the hearing special sense easily. We are seeing the results, the fruitful results. The journey was started in 1980 with single channel approach, up to 1990 multi-channel approach, 2012, 22. We are able to do all the places with all the modern equipment and devices. Like that. And also here I want to quote one of the first person, first graduate. What is the greatness in the graduation? She is a blind and also deaf and dumb. The Helen Keller. She says, blindness cuts off us from the things, but deafness cuts off from the people. That's important. And also she says, I'm just as deaf as I am blind. The problem of deafness are deeper and more complex, if not more important than some blindness. Deafness is much worse misfortune, but means the loss of the most vital stimulus, the sound of the voice that brings language, sets thoughts, and keeps her in the faithful company of truly meant to total environment. And also, she wishes if God appears in front of her, if you want to only wish one special sense, she want to ask the hearing only, not the vision. She developed the speech and language through various methods of licking from the keeping our hands on the mouth and lips and the throat of the other opposite persons. She learned to like that. She also delivered so many lectures and become a politician in the first person. And also, you can see as a 80%, we know that the hearing mechanism, the central audit system is highly plastic in early childhood. During periods of the increased cortical plasticity, sensory deprivation, that means hearing loss, can lead to developmental abnormalities in the cortical areas. However, the fact that the cortex is highly plastic also means that the intervention can produce positive effects. Here's the point. The intervention will produce the positive effects because the time during which the cortex is most responsive to interventions is finite. Some sort of time only we can stimulate the special cortex. Proper timing of intervention is vital, because at least two factors may be important for taking, that is, one, the input for stimulation and timing. These two factors have proven that critical to the plasticity of artery cortex within children with a sensory hearing loss. That's why the early intervention is more important. And also, do you know when the baby hears the first sound? I think 8 seconds may be knowing or not. The baby starts hearing from 18th week of intrauterine pregnancy. And by the 24th week, the baby is more sensitive to sound. By 25 to 26 weeks of intrauterine pregnancy, baby responds to the noise and voice in the womb. It was clearly shown of the movie also. Surya and all, they brought the kid. Before birth, they used to hear the Bhagavad and all other issues and also put things to the baby. And also these are the artery connections. I don't take much time. Here the first bilateral. Why we are doing the unilateral or bilateral? It also, whenever can stimulate the one ear outflow, the opposite cortex also stimulated. The first binaural interpretation occurs in the superior auditory nucleus, that is transmitted to the primary artery cortex, that is the broadband particle, that is present in the under superior ciliary layers. And also one more point I want to stress here. See, the science behind development subcortical to cortical connections. In the first year of life, neurons in the artery registry are developed. Why? Because crudely say that we are born with the hardware. The God has given the entire part of the brain and heart. We have to load the software, the proper time. Like a computer, if you load the changes hardware, we can't understand. Like that, the child has to load the software in a proper time. That is, the time is below 12 months only. What happens below 1 year? The billions of major neural connections are being formed. Number of synapses are increases from 24 to 1000 trillion. You can't imagine the connections, interconnections between the particle neurons, 24 to 1 trillion. See the number of neural interconnections, see there. If you won't stimulate it in a proper time, the interconnections will from the primary artery cortex to the secondary cortical areas. That's the thing. And also one more thing I want to stress here. Nowadays, everyone having the mobile field, mobile era. From the age of the 2 years kids also they are giving the mobiles. It leading to the behavioral abnormalities. Some of them they are naming as autism. That is not at all autism. Behavioral abnormalities. The child's brain goes into the systems. They won't come back if you want to train in the proper time. And that's the most thing I have observed after COVID era. And also, what is the sensitive period? The time frame of optimal neuroplasticity, even if the sound being introduced to the artery cortex and promote normal age appropriate development. Here, the problem is happening with the kid. If you won't give the stimulus, artery stimulus to the by the age in appropriate period, the artery cortex will not develop any problem. And also, the critical period of neuroplasticity denotes a sudden cutoff after which the neural system is unable to adopt. But I don't know about this because nature is great. In previous days, we have seen the Vayojan Vidya. The older age people also able to learn something like that. Neural plasticity is there. If you try, the person may develop the speech, but the language is very difficult scenario. It's not at all. I don't also have very experience about that. Impact of hearing loss. What happens if the person is unable to hear properly? The functional impact is the most thing is that you are unable to communicate. Then the spoken language development is often related with unaddressed hearing loss. This is the functional impact. And also social emotional impact is observed in the seniors in our routine day-to-day practice also. Seniors are not willing to get the hearing aid, even though they have the hearing difficulty. What happens is exclusion from the communication can have significant impact on everyday life, causing feelings of loneliness. It was observed in so many places, and isolation and frustration, particularly among the older people with care losses. It also has so many health hazards also, and also discharge from the hospitals of the hearing disabled person compared to normal person is 1 to 2 weeks delay was there. There's the importance of hearing. And also who estimate the unaddressed hearing loss was in the global cost of $750 billion. This includes only health sector costs, excluding the cost of hearing devices to provide education support, long-term productivity, and special studies. These are the misfacts and clinical facts, misconceptions. All we have are misconceptions. See, the hearing in advance, these are the Western regions, not our Indian conditions. Parents will know the child has hearing loss by the time the child 2 to 3 months of age. Prior to the universal screening, the average time is 2 to 3 years. Like that, these are the misconceptions. Both of these are missing issues. One, in our area, because of the consanguinity and illiteracy and also some other beliefs, no one need to get tested right before 5 years. Why I'm stressing the point is the golden age is the before 1 year, and also the eligible area is to get the any benefit from central government or state government, any kind of program is the 5 years. These are the costly surgeries freely available. 12 lakhs of surgeries freely we are doing for 5 years kids without having any expenses from the patient. But the message is not reaching to the people. My aim is to make aware of the people. There are so many solutions available to take the healing class if they come in a proper age time. Now here I'm going to I'll start the continue the lecture afterwards because I want to go to the OT and make the surgical life setup. Meanwhile, the other talks will go on. Thank you. So, thank you, sir. Thank you for the wonderful lecture. So now we have a talk on audio perspective. Mr. Saresh from Advanced Prayers is writing. Hello. First of all, good morning, all of you. For having me here to talk about the audiological perspective to how to set up a cochlear implantation program. Because we all know that hearing is most important sense and what it affects if you are not sure, and it is not only on your hearing aspect but the entire aspect of your life, not only for the patient but also for the people around you. So, if you want to successfully run a CI program, it is not just a one solution. Surgery is the beginning, but there are long-term journey and there are a lot of relay stations in between. So, we'll be talking about all these things. So, you can counsel the families and give them a realistic expectations. First of all, it is very important for us to know what is the importance. We all know that around 800 million people worldwide are affected by the hearing loss. And as rightly mentioned by doctor, it is not just a hearing person, but it affects every aspect of your well-being. If you consider the WHO's definition of well-being, so it highlights not only your physical well-being but mental as well as social. So your hearing loss disconnects you from your physical well-being, cutting down your sound sense. Then you have a lot of other aspects on your social life and your mental aspects also. So it is very important to start looking at this particular aspect at the early stage. We talked about early intervention. But what are the stage? How can you identify whether like this person is ideal candidate for CI or no? So we are going to have a look at that thing. Under Sonova, advanced bionics has this belief that we are dedicated to helping patients everywhere for better connect with their families, friends, passion, and their world. So we are here to give the powerful connection to the life. And how we give this? As I said, this is not just a one-step procedure, but it's a journey. So we'll be having at these aspects. First of all, we have to identify the patients who require like rehabilitation when it comes to hearing loss. So first of all, we need to have some protocols and we need to highlight some criteria to do the early identification and follow up with the intervention. Then we will see whether even if you have hearing loss, we all know that there are various degrees of hearing losses, various types of hearing loss. So every individual who is having hearing loss, or you can say the significant amount of hearing loss, can they go for cochlear implant or not? So there are other options like we all know that hearing aids are available.
you can do surgeries if there is a conductive component, and we can expect the restoration of the hearing sense. But whether it is sensory neural or conductive, we need to like find out that when it goes to your pediatric cases or in adults. In our country, our scenario, whenever we talk about cochlear implantation program, it is mainly focusing on the pediatric because the prelingual hearing losses has more severe effects on the entire lifespan of the child. And recently we have started adult CI surgeries also. So we'll be talking about both the candidacy criteria for that. And the most important thing is everything is done. You have done the basic work. You have identified the case. Now your actual process begins. A patient comes for the surgery and then the post rehabilitation, that is very important. So whenever we counsel families, we always tell them identifying is the biggest thing. Then convincing them for the cochlear implantation is the next station. Surgery is just the 20% of the entire journey. Then your audiological management and rehabilitation, including your speech therapy or verbal therapy, that plays the crucial role, including family members, teachers, and everyone around the child. So why it is important and why it is a team approach that we will be highlighting today. So let's have a look at protocol and what is the protocol for that. We all know that JCI, Joint Committee on Infant Hearing, they have given this criteria for universal newborn hearing screening. Every newborn has to go through the screening protocol because we can't see the usual signs till the child is up to 1.5 years. As sir said, before newborn hearing screening, the average age of detecting the hearing loss was 2 years. And we already seen that a lot of neural connections are developed, and then it is the big, what you can say, emotional trauma for the family to accept that and then start working towards it by the time you are losing out on the critical years of the life of development. So it is very important and it is the right of every newborn baby to get screened for hearing, like vaccination, immunization. Now our country is also coming up with a lot of universal hearing screening program. In Mumbai, BMC hospitals, they are coming up with this program and they will be starting this very soon, like to screen each and every newborn child. So how you are going to start the newborn hearing screening? So there is a set rule 136. Okay, so by the 1 month you have to go through first screening. Okay, so now we are starting before discharge. You have to screen the way. And if you get the referral, then you will have to call them for again the second stage of screening by the 3 months, and then you do the detailed diagnosis, like diagnostic test. And once you confirm, then you should start the intervention within 6 months. So 136 is the golden rule that is given by Early Hearing Detection and Intervention Committee with the JCIX. So this is how it works. If you see in newborn NICU, earlier they were focusing only on NICU infants with some high risk, like lower guts for low birth weight. There are some complications during the birth. But now we are focusing on well baby also. So everybody has to get through this screening program. We usually use these two tools, OAE, auto acoustic emission, and heavier screening. But OAE is very handy and it takes less time, it is quicker, and even if you have less manpower, you can train the nurse staff also to just get the voice training done. So OA is widely choose tool for newborn hearing screening. You just have to do the screening. Whether you get referred, then you have to call them for the next follow-up after 3 months. If you get passed, then you still have to look at the factor because this kid is high risk baby. Okay, if you're then you have to call them for the detailed evaluation. If you don't find anything, then again that is fine. But if you find the hearing loss, then you have to immediately start the intervention process. Okay, same for the well baby. OA screening refer, you just recommend them to come for the follow-up screening. If they have like failed the screening criteria, then you go for the detailed intervention. Otherwise, you can just release that patient. So this protocol has to be adopted in every hospital where we are running this cochlear implantation program, so that you can screen the babies at the correct time and you will have better outcomes in the later stage. Okay, we all know that earlier is the better, and there are a lot of studies done the age of implantation and the outcomes. So when I was doing my masters, so I did the dissertation on the same topic. The child were implanted before 3 years of age and child were implanted after 5 years of age. And I compared a lot of other aspects, including their speech and hearing development, academic performance, social connect, their ability to being in the society. So there is a vast difference. And I also interviewed the parents of this child. So family members also highlighted the fact that those who were implanted earlier, like less than 3 years, or you can say the within critical period for speech and language development, they have shown all around greater results on all these factors. So early intervention is the key when we are running the cochlear implantation program. Identifying the right candidacy. As I said, yes, you have done the screening, child is having some amount of hearing loss, but we are not sure whether we can straight away jump into the cochlear implantation program or we can still do the hearing assessment with the hearing aids and other things. So we'll have to do all these things. Before that, we will have a look at the cochlear implantation, how it actually works. So cochlear implantation is the electronic device which is the most sophisticated technological solution available for sensory neural hearing losses. As Sir rightly mentioned that hearing that sets us apart from other living organisms. Because of sense of hearing, we are able to communicate with our we can share our thoughts, we can discuss things, and we can solve a lot of problems. So that is how the hearing sense of communication is of our evolution over the period of time. So with the cochlear implantation, you are directly stimulating your auditory nerve with the current. So we are not following the outer ear, middle ear, and inner ear the natural way, but this is the processor which has got the microphone. It does everything. This is the engine of the system and it converts the environmental acoustic signal into the electric signal, which is transmitted by the RF cable to the internal signal to receiver package. It converts the signal into small current and it stimulates the auditory nerve, which goes to the auditory cortex. Okay, so this is how basically cochlear implantation works. And now let's look at the criteria. Earlier it was told that for children, like for pediatrics, 12 months and older, they need to have profound bilateral sensorineural hearing loss and little or no benefit with the hearing aid. So how do you assess the little or no benefit with the hearing aid? There are different ways to test that. We have developed a protocol that we are like visual reinforced audiometry in which with special condition we put the child with the hearing aids and we train them to give the response to the sound and we can see whether the child is getting enough amplification to the hearing aid or not. For adults, 18 years plus, so in India now we have expanded adults like 70, 75 years old also. So there is no upper limit for that. For adults, the criteria is severe to profound hearing loss. It was the older one, but now revised one is they are saying moderate to profound hearing loss. And if they have less than 50% speech recognition with the hearing aid on open set sentence recognition. So open set sentence recognition is the test which is developed and it is normalized depending upon your language. So there are a lot of test material depending upon various languages. So we have different set for Hindi, Marathi, Telugu for that. So this test material is developed and we use this sentence recognition material to present them in the specialized condition where they have to respond to it. And if their score is less than 50%, it means they are not getting suitable benefit from the hearing aid and hence it becomes the candidate for cochlear implantation. Okay, you must have seen the speech banana on the audio there, where we test, like we usually test 250 hertz to 8 kilohertz, which is most important frequency range to develop a communication. We all know that we are from 20 hertz to 20 kilohertz, but when we talk about the hearing impaired population, we only focus on 250 hertz to 8 kilohertz, which is responsible for your human communication. Whatever the phoning we can produce while the human larynx, if you spectrally analyze that, it falls into this range. So that is why we focus on that range. And if the benefit with the hearing aid is not coming into that speed banana, we say it is the limited benefit and this person can be the candidate for cochlear implantation program. So for children, again, FDA says that 12 to 17 months. But if you consider the radiological factors, if the mustard bone thickness is fair enough to go for the implantation, implantation I have done for 10 months old, yeah, 11-month-old babies also in India. Okay. So this is the criteria. If you see the look at the audiogram, this is severe to perform for adult is the same. Even now there is a development in the candidacy sector, even if you have a single-sided techniques. Then we had some, what you can say, the traditional way of solving that problem with the cross hearing and contralateral routing of signal. But now, for single-sided deafness, people are considering cochlear implantation as a solution. Now let's have a look at the steps. And that step is not the one step, it is the journey. First of all, you have to idealize the candidate through the assessment. Then you have to consider whether it's candidate for bilateral or unilateral. In India, more than 80% cases are unilateral because of affordability. Majority of the cochlear implant users are getting some assistance either through government programs or some private donations kind of a thing. And whenever it is funded, they only focus on one. At least they need to get minimum. But if you see the global standards, they are highlighting on bilateral implantation. Then you will have to look at the pre-operative medical assessment. There are some things to be taken care during surgery, post-op medical appointments, post-op audiological appointments, and then rehabilitation. So these are the steps, and you have to talk about these steps when you start talking about the cochlear implantation to the family, because many a times they are having their own ideas. Like if my child is getting operated, then from very next day he'll start hearing. So many a times they feel that, but you need to spend some time and you need to counsel them thoroughly, like how it is going to happen. Because many a times one of the members from the family that understands and other family members or the significant others, they are having their own thoughts, they are having their own ideas. Then they come and immediately ask him, sir, now child has been implanted since 3 months, 6 months now, is still not talking, and they eventually stop using, and then this is very sad story. So it is very important to spend equal amount of time counseling parents and the significant others. If you see pre-operative hearing assessment, we already did that. OA is the first screening tool, then not into the VERA for the diagnosis, and this is the visual reinforcement audiometry. So child is fitted with the hearing aid, and then we are looking at the child responses, whether he's getting the enough required amplification or no. If we are saying that even the perfectly fitted described hearing aid is not giving the enough uh, benefit, then this is the suitable candidate for the cochlear implantation. Okay, earlier it was said that you have to take the hearing aid use minimum for 6 months. But now, then the recent study shows that if you are giving the 6 months and you clearly see that child is not getting responses, you are just wasting the time. So now, even 1 to 2 months of the hearing aid usage, you can do the follow-up testing with the hearing aid. You can start therapy. You can start a visit training. And if child is not getting the benefit, then you can straight away jump into the CI program. Next is your radiological assessment. It is very important because we know that sensory neural hearing loss can be possible because of many reasons. Okay, there are different aplasias, auditory absence. There are any number of conditions. So if you want to go with the cochlear implantation, you need to know that yes, there is a cochlea which is well formed. Or even if there are cases like IP1, IP2, they are getting implanted, but surgeon need to have the roadmap to decide on the which side. Okay, you need to do your CT scan and MRI. You have to be 100% sure about the thickness of the mastoid bone, the position of the cochlea, the facial nerve, and I think we have one special talk on radiological aspects of it. So we'll be talking about that more. But this is very, very important and crucial aspect. If you have not done the radiological assessment, you cannot consider the child is ideal candidate for cochlear implant or not. Yes, radiologically he is, but for surgical outcomes, we need to have some things at place. If you are not sure of that, then we won't be able to start the cochlear implantation program for that particular case. Immunization and vaccination is also very important, like for your meningitis and other things you need to be very much sure about that child is gone through the immunization program, and then only you can proceed further. Now we will have a look at the intra-op and post-op things. Intra-op measurement, we all know that we check two aspects. One is your impedances of the electrode, and second is your NRI, NRI neural response imaging. So what exactly happens and why it is important to have an audiologist or somebody to check the impedances and NRI. So these are just the factors, and this can be one of the, what you can say, the indicators that yes, the implantation has been successfully done and we can expect the better outcomes. So impedances, if you see like physically, it is just a resistance to the flow of current. So we just have to check the status of the each and every electrode. Now we are using multi-electrode array with advanced windings. It is 16 electrodes. And we also do the electrode conditioning. So in electrode conditioning, we are just sending a low level of stimulation because during the insertion, many times while drilling, waters can go inside or there is a blood drop or something like that. So because of that, you may not get the good impedance. So then in that situation, you will have to run the conditioning and then you get the better impedances for that. So start getting impedances, the window looks like this. There is a color indication. Whenever you get the electrodes in the green color, it means ranging from 1 to 30 kilo ohms. It is considered as a normal. Purple is short. For example, if there is some damage kind of a thing while telling the electrode or something like that, then purple is the short where the impedance is very low. It means it is not at all resisting the current. So it is ideally recommended to shut down that child so that child will not have excessive current going on. And yellow is open. So it is also very important to do the impedance check out of the box before inserting into the cochlea. If you do the impedances, you get all electrodes in the open range. So for example, because of some IP conditions or there is some resistance to the insertion like ossified cochlea and all. So in that cases, you may not be able to get the 100% insertion. Few electrodes may remain outside. So in that situation, you can get this open electrode. Like first 4 years have gone in and last 2 are still outside of the cochlea. So last 2 will come open in the impedances window. So this is how you have to judge the status of the electrode functioning fine or not. Next stage is we are giving small amount of current and we are calculating ECAP. ECAP stands for electrically compound action potential. So basically we are sending a current and we are getting the response from the nerve. Like we all know that frequency responses where we have to see the N1 peak, like first negative peak and the second positive peak. If you are getting this kind of responses, it means you are getting good NRS. So again, I am focusing on this fact. This is just a good indicator that your nerve is getting stimulation, and this can be one of the factors that we are expecting better outcome with the cochlear implantation. But it is not the only predictor that if you are getting good NRS, means you will 100% get the better outcomes. Okay, it is just an indicator. There are other factors also important to consider because many a time it happens that yes sir during intra we got very good NRIs in switch on session, follow up mapping session. We are getting very good responses, but still child is not speaking. So we have to go back and we have to look at the other aspect like how many numbers of are he's wearing it, what is going on in the alternate training, what is going on in the therapy session. So it is not like that if you are getting good NRS, it means the nerve is getting stimulated. But the better hearing and speech outcome, you will have to look at other aspects as well. What factors actually affects the NRI? So it influenced by the neural survival. So that is why we say the earlier the better, where your plasticity is higher or your deafness age or your deprivation period. If you consider the adult case who has got hearing loss at the age of 50 and now he's there in front of you, sir, I'm 65, I cannot hear at all, and now I want to go for a cochlear implantation. So you can ideally consider that his nerve is not getting stimulated since last 15 years. So neural plasticity goes off, and in this kind of cases, like older childs or longer duration period, you get the your NRS responses may be diminished, or you will have to use the higher current to state the NRS. So this can be one of the factor. Then is synchronous neural activity is also one of the important factor to get the good NRS. Electrode placement, because we maintain a position, your all electrodes should be facing superior to the modules. While insertion, it goes properly, but during some trauma or something happens, and then if electrode is displaced, or sometimes it goes into scalar media or surgical insertion, if it is not smooth, then it can go, it can change its direction. So that is also one of the important thing to look at. Electrode impedance is also very important. So everything goes hand in hand. You have to correlate all the factors to get the what exactly affecting your inner eyes. Next is, we talked about there is external component and internal component, but which technology you are giving, what technology you are using to steer that current is also important. Being an AV, AV was one of the late joiners or late comers into the CI industry in 1996 and 97. But if you see the technological development, AV is the major contributor, because we spent much like more than 20% into R&D to focus on, because this internal device, it is going to be with the patient for a lifelong. So what technology we are using, that creates a lot of problems. So currently we are using high res TIMA. High res stands for high resolution, and what happens into this we will talk about in the coming slides. So in high-res, we have two electrodes. One is high-res CNJ and high-res mid-scalar. So both they like have the sliver configuration, so that there is no need to drill your bone too much. It is just a 4.5 mm thick at the thickest part. Okay, so if you can see this, this is the 4.5 mm thick, and this is made in a such a way that it is suitable. The same implant is suitable right from the your 12 months old baby to the adult implant. Okay, it is made up with the some industrial standard for impact resistance, because if you get any trauma or any hit from this side, so it should not start dysfunctioning. So it is already surpassing the impact resistance, that is more than 2.5 joules, and it is again suitable for all ages. So if you see, these are the dimensions. It's 28 mm to 56 mm. This is 4.5, the thickest part. And this like the telemetric coil is 3 mm. This is the new technology that we are focusing on, that is 3D. We all know that with implantation, the recipient will have some restrictions throughout his life, whether he is going through some metal detectors or in future. Now we all know that CT scan MRI is a regular practice, and a lot of at every stage you may not know that when we require to go for MRI. Previous implants, they were compatible only for 1.5 Tesla MRI, that the special packaging you need to consider your radiology before going for the MRI. But this 3D technology, which is 100% compatible with 3 Tesla MRIs. So even if you want to go for a 3 Tesla MRI, you can just remove your external simulator, you can go straight away walking into the MRI. Why this is possible? Because in this internal magnet, we are not using one solid magnet, but we are using 4 cylindrical magnet rings. Okay, so that magnets rotate in this plane, so that is 2 dimension, and these rings can also rotate around their own axis. So it is rotating like this, and all 4 cylinders are rotating around their axis. So it is like a 3 dimensional. So if you go for an NRI, MRIs, now it is in this ideal position, the magnetic radiation is off. But if you start, then it rotates as per the external magnetic force. So it is 100% 3 Tesla MRI safe, and child will not experience any kind of torque or pain or pull kind of a sensation. So if you consider if child is getting implanted before 5 years of age and you are expecting average life expectancy, so you may not know that at what stage of life he will have to go to MRI. And 3 Tesla MRI with older implants, you need to have a small surgical process where you have to remove this magnet, then you go for a MRI, and then again reinsertion of the magnet. So child is going off air, or basically he is not listening for 20 to 15 to 20 days. But with this technology, this will not happen. So it is 100% 3 Tesla MRI proof. So we have two electrode arrays. Like one is slim J. This is lateral wall electrode. So it is not straight, but just slightly curves. If you see the if you get a J, it is slim J. It is not curved like this, but just a little bit for the proper insertion. So this is the slim J. It is lateral wall electrode, and this is mid scalar. So it is pre-contour. Okay, this is hugging towards the modulus. So if you want to preserve the structures of intercostal structure, other hair cells and all, if you have configuration like there is some amount of natural hearing in lower frequencies and the high frequencies are toned down, then this kind of a electrostructure is better. But again, you have to keep both options to the recipients, and doctor should be knowing both the things that what I can offer to my patients. So these are two technologies which is available with high-res ultra and high-res ultra 3D. Now we talked about internal implant. Yes, the surgery is done. Now we are doing the switch off. We are cleaning the sound processor, and it has to be efficient enough to steer all these things and give the optimum input to the internal implant. Okay. Yeah. We'll be focusing, like we all know that whenever we analyze the sound, it is amplitude, time, and frequency. So if you see this, EV is giving temporal resolution up to 83,000 pulses per second. Spectral resolution means the frequency, it has got 120 virtual bands within the 16 channels. And input dynamic range, that is the loudness that you can hear from the slightest to the loudest, is 80 dB. So this is how you hear, and these are some what you can say, the USP technologies from the advanced bionic. You have proprietary G mic, which is sitting next in front of your pinna, so you get the pinna effect. Because whenever you put microphones here or here, then it loses its naturalness. So you need to have microphones at the pinna, so you are getting that high frequency boost. So it gives towards the natural hearing, and we have 100% waterproof solution with the aqua also. So we are not limiting the child in one particular situation. You just have to listen like this. You cannot go like your friends and have swimming session, or you cannot go and play in water or dances in the rain. So with cochlear implant also, child can do each and everything, and he can function as normal as his any of age mates or peers. Last is therapy. So we all know that it is not just done by audiologists or the ENT surgeons, but your speech therapists, your AVTs, your psychologists, your social workers, counselors, school teacher, everybody comes into play, and they play a significant role in this. Okay, so these are the things that we do in the post rehab. You have to be regular in therapy. Okay. You may not need to learn the language like your mother tongue with the formal section. But if you want to learn second language, third language, we all know how difficult it is. So in that way, we have to be very regular with the therapy sessions, and if the child is not attending that, we need to highlight that factor to the parents. And we have a lot of online portals available like rehab, like AB. This is the online portal where you can find a lot of online activities parents can access by themselves. Hearingsuccess.com is also there for adults. So you can log in as a parent, as a recipient, as a teacher, and you can learn a lot of new training activities. And hearing journey is one more portal. So there is online option available, and being a cochlear implant company, we are there from very first day and throughout this journey. So this is the long-term process, and ENT students plays a crucial role, and it is very important for us to understand how it is going to be. So that is why we have to know all the relay station, and we all know that if you want to win the relay race, that each and every member from your team has to perform at the 100%. Even if you have 1% point, it is not enough to win the 4 by 100 relay race. So everybody plays a crucial role, and this is how we achieve the great results. So thank you so much for your time and attention.
Thank you, Dr. Kumar, for the narrative description of audiological aspects of cochlear implant surgery and part of cochlear implant surgery. Within the short time, we are going to start surgery also. Before that, we have anesthetic considerations in the cochlear implant surgery. Dr. Sudhir Kumar is going to talk on this. Is it?
Yes.
Your name is Sudhir?
Yes.
Okay, he is going to talk on this. In this time, let me remind one thing. As already Dr. Sriharsha has told the importance of hearing in India and everywhere. He told about many things about Helen Keller. I want to share one quotation from Helen Keller. Then we will start on this presentation. Helen Keller, you know all that. She is both blind and deaf. Once she said from the word, though I can't see the sun, I can feel the warmth of it. Though I can't see the flowers, I can feel the fragrance of it. But there is no alternative for not hearing the melodious sounds in the world. That shows the person who has lost both vision and the hearing, he knows the importance of which is most important. That's why hearing is much more important than vision. Like that, she suffered more, and also he has asked God to give hearing rather than like this vision. This is the importance of hearing. Now let us start this.
Good morning, delegates. Today we are talking about this anesthetic perspective for cochlear implants, which will be boring to you, but I don't take much time. See, what we should see in the perioperative period. Does intraoperative consideration will give out the outcome any difference? What are the post-operative concerns and cochlear implant cases coming for other surgeries that we'll see. In preoperative age group, generally will be around 2 to 3 years, ideally, where we know most of studies show that around 2.5 years of age, getting the cochlear implants or getting the good results. And to identify the facial now also, the ridges develop around 2 years. And our patients are both deaf and mute. So associated congenital surrounds should be ruled out to see any upper respiratory tract infection. Acute and chronic respiratory otitis media should be well controlled. And any milestone delays of cerebral palsy or neuromotor deficits are present. And we should see any psychiatric medications and psychiatric illness changes involved. These are the common syndromes that are adjacent with deficit and mute. This is Richard Collins, and where patient dysplasia is seen and difficult airway. And clips where we know the positioning of surgery is also difficult because of cervical fusion. This we can see in Pendon syndrome. This chain will be associated with goiter and hypothyroidism also. In Alford syndrome, we should see the renal involvement with either and endocrinal deficit. And in general language and both prolonged QT intervals are seen. So in preoperative period, both echo and ECG also is must for this children. And we know this routine fasting guidelines. Generally, for age group of 2 to 4, we consider about this breastfeeding over 4 hours and infant formula feeds for 6 hours. And this informed consent is which is the major thing, because this is not a like normal surgery where we go out of the surgery and everything is okay. It takes a long time to give the output. Do really this anesthesia makes the difference in outcome? That is a today's talk which we are not concerned. Generally, we use this sedation of ketamine, midazolam, and atropine to sedate the baby and to take him to the operation theaters, where 276 patients were done for audiometry with this combination. They didn't see any difference in audiometric studies by giving this drugs. And this is the standard maneuver which we use like propofol, fentanyl, and metronomium, and dexmedetomidine, and rectal paracetamol. What are the main intraoperative consideration that we take in this case of cochlear implants? Does it make any difference? Usually, the surgical time will be around 3 hours for bilateral. Both the communication between surgeon and anesthesiologist plays a major role. And we used to discourage the cardiac after placing the implant because of electrical interference. Do we really need a hypertensive anesthesia? Study says no. Just a head elevation and maintaining the baseline blood pressure is enough. And two main intraoperative methods identifying of a patient now. It is made by electrical stimulus. So we avoid using intraoperative muscle reluctance so that surgeon can identify the patient now better. And TIVA, which we don't use muscle reluctance, but propofol infusion, it is better. And we have two components, namely this stable reflex threshold and compound action potential. It is mainly of determinant of maximum comfort level, which is defined by the loud soldered test without pain, and a determinant of noise threshold with the low acoustic stimulus perceived as sound. This anesthetic drugs will this affect both stability reflex and compound action potential. There is a study of around 110 patients they have done. This is from Iran. They see that there is a strong correlation between level of hypnosis and median stability reflex. This increase in ESRT is seen with increase in concentration of inhalational agents, and the dose-dependent suppression is seen with stability reflex, where isoflurane is abolishing almost the reflex at 1.5 Mach. So generally we avoid inhalational agents intraoperatively. And this is the another study of effectiveness of dexmedetomidine for sedation and auditory brainstem reflux test. This is showing that dexmedetomidine doesn't make any difference in this both stability reflex studies and compounding action potential, where compounding action potential is not affected by either inhalational agents or IV agents. Propofol and midazolam has very minimal effect on this both compound and stability reflex. And this is another study showing that stability reflex measurement during the surgery and post-op. This has shown that intraoperative stability reflex thresholds is more than post-operative values. It is associated with in meningitis patient also where higher stability reflex were seen in intraoperative period. And this is a routine fluid management. Just when we give about 20 ml per kg of intraoperatively will prevent hypothermia. And generally we don't use Polish catheterization, just blood venting before the surgery will be practiced. And the deeper plane of extubation should be maintained so that after bucking and coughing, it may migrate the implant. And this post-operative care, this post-operative recovery starts from pre-operative. Where at the admission time, counseling to the parents, optimization, avoid bowel preparations, avoid prolonged fastings, avoid this administration of non-opioid anesthesia, and intraoperatively standard anesthetic protocol and antibiotic prophylaxis with very minimal invasives, no routine use of NG tubes. Then in post-operative period, early oral nutrition, early mobilization, and urinary catheter removal. This all will help us for recovering, enhancement recovery of after the surgery. Then another main consideration that is post-operative vomiting in children, which is the major concern because our patient will fall in this high group because of surgery duration is greater than 30 minutes and the surgery is middle ear surgeries and we use all opioid and anticholinergics. And these are the common drugs which we use. This all. And this granisetron is now promising because of its long acting. This is the post-operative pain management. This we explained. Generally, we use simple NSAID, whether it is rectal or oral. These are the common doses that we use. Ibuprofen 10 mg per kg or diclofenac or 1 ml per kg, or oral also same, or intravenous this ketorolac 0.5 to 1 mg is better in controlling the pain management. And we use this Tramadol also, Tramadol 1 to 1.5. Then this is another topic where emergency delirium. delirium in this post-operative period, which is not considered much, but it is very important because ENT surgeries in this cochlear implant, it is almost showing us 42%, and there where we use in post-operative pain, inadequate post-operative control of pain also will lead to delirium because this patient's it is very difficult to communicate with this children. We use dexmedetomidine to decrease that delirium, and simple midazolam and gabapentin or ketamine also will be helpful to decrease this delirium. And this as the number of goals of cochlear implant cases, they will be coming for other surgeries in the rest of their life. That is also one consideration. Generally, we should even avoid bipolar batteries directly onto this implant. Then electroconvulsive therapy. Mostly, this children are associated with psychiatric illness, so better to avoid ECT therapies on that. And direct radiotherapy directly can cause damage to this implant. And MRI, as now we said, now newer devices are there which are MRI compatibility. Previously, they should be removed by a small surgery of external magnet. This is the take-home message. So complete evaluation, preoperative evaluation is must, and TIVA is best technique. Anesthetic techniques and drugs have minimal effect on overall outcome. Step towards enhanced recovery after the surgery is practiced in routine. Emergency delirium to be considered and they should be prevented. And elective procedure, safety is our main priority. Teamwork and multidisciplinary approach will be improving outcome. Newer drugs are showing promising results for the overall outcome. I'm a little bit fast because it is clear for surgery.
Because we have to go for surgery.
It's
Some doubt, they ask.
Please elaborate about this TIVA technique that's been taken.
TIVA.
TIVA technique. Actually, what TIVA technique is, generally in routine, we will use muscle electrode also, like attractive or vector. But in this TIVA technique, we don't use muscle electrodes because you want to elicit this stability reflex and you want to see this compounding factor. Just at the time of intubation, we will give attractive or vector, which will be lasting around 30 minutes maximum. So that will be helpful to make your skin preparation, everything, and reaching the bone building. At that time, it will be completed where you want to put the device and see that. At that time, we will put the propofol infusion, propofol and fentanyl infusion, so that we actually don't give any muscle relaxation. That is the key.
What is the expansion of TIVA?
Total intravenous anesthetic agents.
Total intravenous.
Intravenous. And we are avoiding this inhalation agents also. Generally, we use sevoflurane or acid, which is showing that it is decrement in the response of peptide reflex. Yes.
Okay, any other doubts we can clarify later? Because we need to go to theatre. Case is going to be started.
Thank you. Thank you, sir.
How much time is there?
10 minutes will be.
You know, they can talk there. Other lectures after the yes, our plan of the comprehensive. So we go to the so that's comprehensive. Hold on, sir.
Hello?
Hello?
Sir, am I audible?
Okay, sir.
Hello?
Hello?
Sir, am I audible?
Audible.
Sir, audible, sir?
Audible.
ఇది బయట ఎక్స్టర్నల్ కెమెరా లాగా వాడుతున్నాము ఇక్కడ ఇంటర్నల్ గా
Picture రాలయ్యా పిక్చర్
ఇస్తున్నారు పిక్చర్ ట్రాన్స్మిట్ చేయమని కేసు తీసుకోండి. హలో గట్టి పిక్చర్ Are you getting the
Hello, sir. Yes, sir. Sir, picture రాలేదు sir.
పిక్చర్ రాలేదు అంటే ఓటీ అంటే యాక్చువల్ పిక్చర్ ఏమో సెపరేట్ గా ఇస్తున్నారండి అది వీడియో ఇక్కడ నేను హలో సార్ ఓటీ పిక్చర్ వస్తుందా సార్? Sir, you are getting the OT picture?
Yes, sir. Yes, sir.
Yes, sir. You can see the layout of the operation theatre.
Sir, the picture is not clear, sir.
Which is not clear?
Not clear.
Oh, yes, sir. Sorry. Audio. Audio. Picture because I'm using my XL camera. That my phone has XL camera. You can say getting the picture of the baby.
Sir,
Hello. Respond.
you can accept.
అమ్మా అక్కడ వెబ్ క్యామ్ ఆపేసేసి సరే ఎవరైనా మాట్లాడుతున్నారు అక్కడ వినపడుతుందా నా వాయిస్? అది ఆపేసాం ఇది ఇంకా ఇస్తాం ముందు ఇది చెప్దామని నా వాయిస్ అంటే హలో హలో వినపడుతుందండి? You can hear me?
Yes, sir.
Right. Hello? Now we are going to internet. Sorry. Internet. అమ్మా మన ఐటీ వాళ్ళు వచ్చి నాకు ఇంటర్నెట్ వైఫై కావాలి, ఇక్కడ వస్తారా రాదా కనుక్కో. ఇంటర్నెట్ వైఫై. You can see the position of placing the position. Hey, Shampu.
Sir, video is not clear.
Because I'm transmitting from my phone, not to the micro properly. So there is no signal. We are getting the baby. Hello. Am I audible to you?
Yes, sir.
Okay. We didn't start with the microscopic camera.
Okay, sir.
That we will start. And also first see the external picture because we want to explain the position also. We want to explain the position also. Hello. Hello. Now the patient is going to intubate.
Sir, you can show it in smaller picture.
వాయిస్ నాకే వస్తుంది బికాస్ ఎక్కువ వస్తుంది.
Sir, are you able to hear, sir?
మీ మాట నాకు వినపడుతుంది కానీ మీది నాకు 2 సార్లు ఎక్కువ వస్తుంది అతని నుంచి.
Sir,
ఒక్క నిమిషం. హలో. ఇప్పుడు మాట్లాడమ్మా రాఘవేంద్ర. వాయిస్ వస్తుంది. ఇప్పుడు మనకి ఏంటంటే కెమెరాలో వీడియో చూపించడానికి ఇక్కడ ఇంటర్నెట్ నా ఫోన్ లో సరిపోవట్లేదు, బయట ఎక్స్టర్నల్ కెమెరా. అది ఓకే. కెమెరా కెమెరా లేదు కదా. You will get the microscope picture easily, but outside we want to show the positioning, position.
Yes.
See the position. I want to tell you it will be easier to set up everything in the operation theater. Minimal equipment required. Able to see the picture?
Sir, I lost the picture.
Are you able to see the picture?
Sir. Now in a small box. It's coming.
Are you getting the arrangement of the table?
Yes, sir. Just rotate the camera, sir. It's not aligned.
Hello?
Explain, sir. Go ahead. Explain.
Raghavendra?
Sir, వస్తాను సార్ వస్తాను సార్
ఎవరు?
ఓకే
These are the minimum equipment required to do the cochlear implantation. There is no major equipment required. But we should have the one good microscope. Hello?
సార్ ఎస్ సార్
Okay. See, just radiology was given anyway. I'm not going to discuss about the radiology. I will give so many lectures in the online. Just we have to see the trajectory.
సార్ rotate the camera, sir. Rotate the camera.
Okay.
Now it is good, sir. Yes.
You can see this one. You have to find out the trajectory. Trajectory means to introduce the electrode.
Sir, ask somebody to fix the mobile, sir.
నా చేతిలోనే ఉంది.
Not to move, not to move.
Okay. Just see that one. This is a round window niche. Basal turn of cochlea. Basal turn of cochlea. We have to introduce the electrode in this part. Here the left side is, you can see there is a sigmoid series occupying the mastoid cavity. It's very difficult to get the trajectory. It obstructs the path. That's why you have selected the right side. And also it contains some bone marrow. The not fully aerated mastoid. We'll have some difficulty to deal with. Everything I will see. This is a radiological part. It can explain later. First, you can see the position of the patient. The main thing is we have to take the baby inside along with the parents. To elevate the apprehension. And also after intubating, we have the position of the ET tube to the opposite side, and also we have to arrange all the equipment opposite ear. What the side of ear we are doing, the right side, based on the radiological and audiological conditions, we have selected the right ear, and also keep the baby in a position edge of the table. Why? Because I'm telling you from the A to Z. Most of the times we are seeing online on the operating part only. The operating part we can get the information anywhere on the web. But how to make the proper positioning and preparation of the patient also most important. Here, the prior the day we have to remove the hair from the head. Consultation has to be done 1 day prior. We should examine the all over any skin infections all over the body, and also any cold of the baby, any upper respiratory infections we have to rule out. Then after preparation of the head, we have to apply the bedding paint prior night at the side of the surgery, and also it is better to have antibiotic before night. On the day of surgery also we have to give the keto sham. Means antifungal shams we have to give for the baby for the bath. And after head bath, we have to apply the bedding again in the morning. And also after prior to the surgery also, we have to give the anti. Shampoo. Because of the net connectivity, poor net connectivity inside, we don't have any Wi-Fi. Our mobiles are not working properly. We are unable to transmit the external camera. Airtel camera also. Airtel phone. Airtel SIM card. చూపించు you can see how to keep the position of the patient. You have to put the patient in the next table. Sample. I'm taking the patient to the edge of the table. See the edge. Usually our ENT tables have the small head piece. This is the piece, and also we have to keep in a position to make the round window visible. That's why you have to keep a cover under the skull of the baby. You have to place a shoulder like this. Are you able to see that one? Position of the patient also important, and placing the tubes and the microscope also equipment to the opposite side. Then we have to paint the body again. Before going to the wash, I will do the infiltration. Stereo. No. Gloves. Head top light. Templates in there. Metal template. Metal template. Gas fix.
Sir, meanwhile, we can show the CT scan and CT scan.
CT scan. Just usually Sorry for the inconvenience to you. After placing in a position, we have to mark the washer and also implant. Why? Because these are all adult size. These are the small skull. We have to place in a proper position. The implant should not overlap on the processor because metal on metal contacts may cause the skin necrosis and all the exposure of the receiver stimulator. That's why we have to maintain the distance always from here. For that, we have to mark. If you mark also after draping and sterilization, it won't appear. We have habituated to calculate the length, and also for your information sake, these are the markings to be done prior to giving the infiltration. It is better to do the infiltration before actually better to do the infiltration before then I'm showing the infiltration technique immediately. Just after cleaning the area, small needle, we have to give the incision marking. Okay, the types of incisions will be dealt by Ravindra will tell about the surgical steps. Small needle first to shape people. Just see, we have to give the. I am giving here the laziness incision in the post-operative area. First, you have to palpate the tip. You have taken the tip. Usually, by the age of the 2 years, the tip will be totally formed. Just I have marked the tip here. From the tip to the helix, we have taken a curvilinear marking along with the postal crease. Before reaching the helix, it has to be turned posteriorly. This is the area of bone, temporal bone. I will explain after opening the flap. Just see the incision marking because I have given the incision marking with the 26 year half-inch needle. If you give the surgical pen also, it will disappear after cleaning, applying the sterility. And also we have to infiltrate the post-oral area. Just you have to first prick the skin and elevate the skin. It will like a blood. And then with the hydrodissection, if you pushing the medicine in the needle and it can pass up to the tip. See how it is got elevated. This is the one method. Required area we have to infiltrate up to 10 to 12 cc of infiltration. With the same point, we should not remove it. And also you have to go to the leg side of the baby without withdrawing the needle. Again, you can infiltrate. Another technique is you have to pinch the skin and infiltrate. The same distance I'm infiltrating. Again, also you can go hydrodissection or like this, or you can pinch the skin before injecting the drug. So like this, we have to elevate the area. Are you getting the clear picture? Anyone want to respond, please?
Hello.
Are you getting the clear picture? Sir?
Is it able to understand what the steps?
You can see the video. The baby post-oral area infiltration.
They are able to
Just
say.
we are spreading the drug all over the areas required. Just like a clean, clear surgery. There is no great steps or more equipment required. Only simple, like all clean surgeries. We have to give the post-oral infiltration prior going to the washing. I have given this one and keep the thing. I will go on wash. Meanwhile, see the position and also the equipments. So the equipment. Here I
The other staff, yes, sir.
Actual speaking in the law, it's not a potential.
They want to say, but that was a problem.
Okay.
Sure, sure. Hello, someone? Hello?
Sterilium.
Sir, you can shift your microscopic picture, sir, now.
Yes, yes, yes. I'm going to shift the microscope picture. After proper draping the patient, you can see the draping. Because the small thing is, I'm getting echoing from the auditorium for my earphones.
Sir, you can use the speaker, sir.
That's why I'm asking them to set up the speaker.
Use the speaker, sir.
Here, the main point is sterility. How to maintain the utmost sterility for the cochlear implants, because this is a foreign body. Even though biocompatible silicon covered, if any time it is infected, very difficult to treat. That's why we have to minimize the infection and also trespass this in the operation theater under the less number of OT people. It's very simpler, it's very easier. All of you know how to elevate the incisions and flaps for the cavity obliterations like flaps. Here also we give the incision. Incision is different kinds. Post or C-shaped, large C-shaped, lazy S, and also double incisions. That is minimal invasive incisions. One incision for the flap, one incision for the keeping the implant. Now I am preparing the part, applying the betadine. You have to keep the betadine inside the ear canal also. Why? Because if you breach the posterior canal or the skin, the betadine will appear in the operation field. That is called betadine sign. For that, we have to keep some of the betadine in the extraoratory canal also. We have to clean good part, postal area. See the marking, postal incision marking clearly visible by making the 26 gauge 1/2 inch needle only.
Yes, sir.
Now applying the sterilium. Then also you can see the marking. After that, we have to apply the self-adhesive tape. Previously, while I'm learning, they are used to put so many kind of fixations, neuro clips, skin sutures, special equipment and all. So now I'm not at all using any special equipment here. Just simple master retractor. One adhesive drape is enough. Adhesive drape will lessen the another assistant work by keeping the auricle anteriorly. Drape. I will show how to apply the drape here. Okay, done. First, we have to apply the head towel. We have to apply the head towel as usual in every routine ear surgeries. Just you have to explore the rectangular area of the post-oral area. I will show. Just a small head drape. Just keeping the article anteriorly, we have to apply the adhesive drape. Okay. For this, better to have two assistants to hold the drape in a proper manner and come. First, keep the posterior part, then the anterior part you can apply. It's easier. It also keeps the article anteriorly. It's a simple drape, costs around 40 rupees. Then we have to drape properly all over the body in a triangular fashion. Small towel clip. This is about the patient's position. Next, the surgeon's position. We have to take the chair with the support, with the lumbar support, because it takes sometimes more time. You have to safeguard of your spine also. Positioning of the table, position of the surgeon, table kinda down there. And also make the table downwards as much as lower and keep straight, and also always keep any foot small table in the for support of our legs. There you have to keep the foot pedals, and also you have to habituate. You have to sit straight with the spine, and also the foot support. All the powered instruments you have to get habituated with the right leg. Why? Because it's easy to drive cars. Everyone's having the cars nowadays. We know how to accelerate. Like that, you have to use always with the right leg with the powered instruments like micro debrider and also motors. With the left leg, you can use your rotary instruments. If you habituated like that, it's very easier. You are pressing the left leg means you are applying the card. The right leg means the powered instrument. To control the acceleration, and also everyone to habituate like this one. About draped over the table onto the gown. If any instrument falling downwards, it will be here only, because some of the sensitive equipment required while doing the pricks and all, and also the class, it's very difficult to get the second one. That's why it is always better. No instrument fell down, and also we can keep the motor and cartridge cables in our lab. After keeping this is the position of the patient and draping. Are you okay up to this part?
Sir, sir.
Okay. So this is the arrangement. Next, we are going to take the microscope, and also anesthesia machines in the inside head end or the again we can keep it, and also assistants in both sides. Bipolar foot plate, micromotor, and also micromotor also a simpler one you can use. Or somebody has to take it. Cover. At bit now we have to unwrap the microscope. Anybody should not touch the operating area. This is a simple Sanma microscope, not simpler one. This is some higher end. And the selects of microscope also for our ENT surgeries is better to have the small head piece. Why? Because we have to see all the other areas also, not only the microscope view or the peripheral parts also we have to see. That's why the small head is always better than the bigger heads. I have operated all the types of microscopes, including the high-end G's, Leica, and all neuro microscopes, more than 1.5 crore, while operating at the WIMS and Manipal hospitals. They are very cumbersome. They are robotic. It's very difficult to operate also. Then after keeping the microscope, we have to make an angle with the main arm. The suspension arm and the main arm should be keeping an angle. Then only you can control easily. And also the straight, it is better to have the straight head pieces. And also we have to fix the working distance for the maximum magnification. First we have to maximum magnification, and also focal length also should be fixed. Are you able to get the microscopic picture? Start video. Okay. Are you getting the microscope picture? Start video. శౌరెడ్డి గారు వీడియో స్టార్ట్ చేయండి. వీడియో స్టార్ట్ చేయండి. కింద వీడియో అక్కడే కింద ఆడియో పక్కన వీడియో ఇక్కడ మా నువ్వు చూడు పక్కన అది వీడియో పక్కదే. స్టార్ట్ వీడియో స్టార్ట్ కొట్టండి దాని మీద. Okay, are you getting the video now? Video start చేయండి సార్.
Microscopic video we are not getting, sir.
నెట్ కాదు, అక్కడ వీడియో అనవలేదు. వస్తాను చూడండి.
Sir, 90% is there, so
ఐటీ పర్సన్ ఎవరున్నారా ఇక్కడ? ఎవరు లేదు.
yes, sir.
మైక్రోస్కోప్ పవర్ ఆన్ చేయాలి, జస్ట్ పవర్ ఆన్ చేయండి.
Sir, now we are getting, sir.
ఓకే, నౌ యు ఆర్ గెటింగ్ ద పిక్చర్.
Yes, sir.
Yes, okay.
Sir, you make it full screen, sir.
There itself we have to make it full screen.
So microscopic picture, can make it full screen, sir? Is it possible, sir?
There you can change the settings there in your end. In your end, we have to make it on the screen. అక్కడ లేదంటే ఇప్పుడు రైట్ ఇప్పుడు ఏం చేస్తారు, నా హెడ్సెట్ దానికి కనెక్ట్ అయ్యి ఉన్నాయి. ఆడియో కనెక్ట్ చేస్తే అది ఫుల్ స్క్రీన్ అయింది. ఆడియో, వీడియో కాదు.
Sir, you can switch off the external one, sir. You can. Sir, disconnect sir. You can show it in your connect in your or microscopic picture we are not getting, sir. Sir, just a minute. Hello, sir.
ఆడియో ఆప్షన్స్. హలో
Sir, hello, sir.
వినపడుతుందా రాఘవేంద్ర?
Sir, sir, picture of this.
పిక్చర్ వస్తుంది, అక్కడ మీకు ట్రాన్స్మిషన్ వేరేగా ఇస్తారు. దాంట్లోకి నా మాట వినపడుతుందా? ఇక్కడ ఇది కనపడుతుందా? ఇన్సిషన్ రెడీ అయిందా సార్?
Sir, అది external camera తో వస్తుంది, sir.
ఎక్స్టర్నల్ కెమెరాతో వస్తుంది. తర్వాత మైక్రోస్కోప్ కెమెరా వస్తుందా? వెళ్తుందా? అక్కడెక్కడ కనెక్షన్ ఇచ్చారు?
Sir, optic cable
వస్తాడు ఆ పర్సన్ కిందకి వస్తున్నాడు. మా ఆప్టిక్ కేబుల్ తో కనెక్షన్ ఇవ్వడానికి వస్తున్నాడు బయటికి కిందకి. అదర్వైజ్ ఇక్కడ మీకు ఆన్లైన్ లో కనపట్లేదు అక్కడ.
Sir, clear లేదు. Picture చిన్నగా వస్తుంది, sir.
క్లియర్. ఒకసారి దాన్ని ఇక్కడ తీసుకురండి, మొత్తం ల్యాప్టాప్ ఇక్కడ తీసుకురా. Now you are getting the Microsoft picture.
Now we are getting, sir. Sir, you sir disconnecting this one.
వాళ్ళు డైరెక్ట్ గా ఇస్తున్నారు.
Sir, సంపూర్ణ మొబైల్ లో తీసేయండి, sir.
ఏమా
You are speaking with the Sampurna's mobile. అది Bluetooth.
సంపూర్ణ మొబైల్ ఇక్కడ ఉంది, దీనిలో ఆడియో ఆపేయమ్మా.
సార్ రెండు ఉన్నాయి సార్ ఇక్కడ అందుకనే ఇచ్చి కూడా చెప్పాను.
ఆడియో ఓకే. నౌ యూఆర్ గెటింగ్ ద ఎక్సెల్ కెమెరా.
హలో సార్.
ఓకే, టెల్ మీ.
సార్ రైట్ సార్. ఇక్కడ 2 years అవుతుంది సార్. ఒకటి మీరు సంపర్కంలో వీడియో చూపిస్తున్నారు.
మైక్రోస్కోప్ కెమెరా వస్తుందా రావట్లేదా?
వస్తుంది సార్, రెండు చూస్తున్నాయి అంటే రెండు షో అవుతున్నాయి. ఏదో ఒకటి అవుతే మనకి ఫుల్ ఉద్యోగంలో అవుతుంది సార్.
అది ఒకటి చూపిస్తాను, ఒకటి అంటే ఒకటి ఆఫ్ చేస్తే ఒకటి వస్తుంది. నౌ ఐఎమ్ షోయింగ్ ద ఎక్సెల్ కెమెరా. Incisions and all. Elevation of the flap incision you can see. వచ్చారా అన్ని మార్చడానికి? వచ్చారా మా తెలుగు వీడియో ట్రాన్స్మిషన్ కి?
సార్ సార్ నేను ప్రశ్న
సరే ఓకే, ఐఎమ్ గోయింగ్ టు ఎలివేట్ ద ఫ్లాగ్. నైస్. It's very simple. Just like all ear surgeries, we have to give the incision up to the tip of the mass side. The largest incision is just skin. We have to elevate the two types of flaps. If we infiltrate properly, we won't get any bleeding here. See the flaps. Now I'm elevating the subcutaneous flap. Are you getting the picture? Are you getting the picture, Excel camera?
Yes sir.
Because here also I don't use any kind of monopolar, because these are the small teeth, very tender skin. If you use the monopolar cattery, it creates around 400 degrees centigrade. That's why whenever needed, only we use the cautery. Just I'm elevating the skin flap post-operative. After here, you create a pocket. Like the back of the BP handle, just push under the skin, you can create a small pocket where we have to keep the receiver well. I have shown you the example here in the template. Then anteriorly, to put the subcuticular sutures, I'm taking a small thickness under the skin. And also, so here our aim is to elevate the flap. Flaps are also different kind, anteriorly based, posteriorly based, superior based. Here we will elevate the superior based valvular flap. And also sometimes if needed, I am creating a small, and this is my technique. I am elevating a small anterior flap up to the level of aortic canal. See, the stick can pull anteriorly. Just we have to elevate up to the aortic canal. This is the landmark for the anterior landmark aortic canal. Then we have to palpate the tips. This is the tip area. Over the tip area, just give a horizontal stab incision. Nothing more than that. Based on the posterior end of the horizontal stab, you have to come posterior superiorly to elevate the wide U-shaped superior based flap. Is it clear to all of you? Then, based on the anterior part, I'm giving another incision parallel to the aortic canal. From there, we have to elevate from the tip For that, you can use the freeze elevator. Just slip off from the tip of the master. You can get the flap easily. The assistant can pull off from the board.
Hello.
Hello?
Sir, if possible, we focus the microscope also, sir.
Okay, now I focus. Just see the flap. This is the simplest step you have to complete within 2 minutes. This is the flap. You can keep it over. I will take the microscope. Now we are getting the microscope picture.
Sir, we are getting, sir, you take over the technique, sir.
Pardon, what you want?
Sir, external camera, mobile camera, we go step by step.
ఆపేస్తాను ఎక్స్క్లూసివ్ ఆపేస్తాను. Are you getting the picture clearly? Raghavendra?
Yes, sir, it is coming.
Okay, see the area of exposure.
Sir, ask to disconnect here, this Sampurna mobile, sir, to disconnect completely, sir.
సంపూర్ణ పూర్తిగా ఆపేసి పూర్తిగా డిస్కనెక్ట్ చేయాలి. లాగౌట్.
If you,
ఓకే.
so what I'm going to get is,
You're getting the clear picture. Just see the landmarks once again. Just we have elevated the flap, superior based wide U-shaped flap, and also this is a masthead bubble. Routinely, you will do in all kinds of masthead surgeries. You will expose, but little bit exposure of the posterior part. Otherwise, nothing more than. And also, you have to elevate anteriorly. We should have two suction machines.
sir, just to orient us, which is anterior, which is posterior, which is superior.
Okay, you can see this is the superior basal parallel flap. This is superior. This is the anterior. This is the posterior. This is the inferior. Inferior, I am exposing some part of the tip part.
Sir, reduce the magnification, sir, microscope magnification.
Reduce the magnification.
Just to get the orientation, sir, for our audience.
This is the only possible.
Okay, sir. Okay, sir.
This is the neuro microscope. This is the neuro microscope. It has a more focal length than the ENT microscope. That is the main problem. You are getting the picture.
Yes, sir. We are able to see the spinal frenulum.
It opened up.
Muscular areas in back.
Yes, this is the anterior part. You have to elevate this layer up to the canal wall to expose the spina frenulum. As in every routine ENT surgery. See, this is the spina frenulum. This is the posterior part of the jagoma. This is the spina frenulum. We should not more deeper than that. And also, I'm exposing some part of the mastoid chip.
Centralized a little bit, sir. Centralized.
Okay.
Yes, sir. Yes, sir. Now, just
This is the mastoid chip.
okay.
Up to that, I didn't use any kind of special equipment, a small incision. That's all. Here now, I'm applying a small mastoid, self-retaining mastoid retractor. Small mastoid retractor applying from the up, keeping a small gauze piece in the posterior flap to prevent the pressure over the flap. Just keep a small gauze piece posteriorly and open the flaps. Just this is enough. Close. Close in. Come on. Lock just self-retaining hemostatic mastoid retractor applied there. Then a small 2-prong retractor to have the proper exposure. Are you getting the clear picture?
Yes, sir. Picture is clear, sir.
Drill. Here I am showing some of the drilling techniques.
Sir, once again, just orient us. Which one is anterior spinal frenulum?
I will show. Success.
Sir, just checking the monitor also, so that you come to know, sir, whether this is going.
Monitor మంచి పెద్ద చేయండి మైక్రోస్కోప్ పిక్చర్ అక్కడ మైక్రోస్కోప్ పిక్చర్ పెద్ద చేయండి నాకు కనపడేది చెప్పండి
turn the marker towards your face so that you can get.
అంటే మీకేం కనిపిస్తుందో నాకు తెలియదు, డైరెక్ట్ గా వస్తుంది మైక్రోస్కోప్ పిక్చర్ ఇక్కడ. రివర్స్ ఏమైనా వస్తుందా మీకు?
లేదు సార్, మాకు క్లియర్ గా వస్తుంది సార్. సెంట్రలైజేషన్ ఉందా లేదా అనేది ఒకసారి మన పిక్చర్ టోటల్ గా కనబడుతుంది మానిటర్ లో. అందుకని
ఇప్పుడు టోటల్ గా ఇప్పుడు this is the tip of the mastite. This is the root of zygoma. Suction on చేయండి.
సార్ సెంట్రలైజ్ సెంట్రలైజ్
నాకు సెంట్రలైజ్ గానే ఉందమ్మా, మీకు ఏం కనపడుతుందో తెలియదు.
ఓకే సార్, now it looks good.
ఓకే, ఇట్స్ గుడ్.
ఓకే సార్.
ఓకే,
Now it's good sir.
now see, I'm starting drilling from the tip. Always you see in the mastite surgeries suction ఏమి రావట్లేదు. ఇంత వీక్ గా వస్తే కష్టం. ఇంకోటి
If anybody wants to interact, they can use that.
just see the drilling point. It's a very easier. I'm starting drilling from the mastite tip. First I will separate some of the mastite fibers from the tip. Usually in the surgery, mastite surgery, you can mark a horizontal marking and also vertical marking, making these two. But here I'm starting some sort of reverse drilling to make out the tip cells first. To see if tip cells are there or not. These are the tip cells. From basing on the tip cells, you can just come along with the posterior wall of the exploratory canal, parallel to the just a T-shaped drilling. Nothing to worry. The patient having some of the narrow content bone, diploid bone, not fully pneumatized. Is blue color marking sometimes, and also narrow canal and narrow max style. Just along the canal wall, hugging the canal wall, we have to microscope also. See, maybe this is the sinus. See the sinus. That's why I'm worried about this thing. This is also sinus, very contracted mastite. This I'm planning. It is better to plan area, but the electrode is AB. In advanced bionics, we can't use the. It is very difficult to make the area technique small, but the right side is more, left side is more contracted mastite. Somehow the right is better than the left. See, you can see the laterally and anteriorly placed sigmoid sinus. I didn't injure the sigmoid sinus. Before drilling, we have to take care of always the structure. I have changed the barbit into smaller size. Without damaging the sinus, I am able to identify the mastite anthem, the most consistent in the temporal bone. What bone I am drilling is the squamous part of the temporal bone. Nothing to worry about all the issues here. The only this bone doesn't contain any important structures. This microscope also very new too for me. I forgot to adjust the optics into 0 levels. ఓకే. హలో, ఎవరు చెప్పమ్మా? నాకేం వినపట్లేదు. నా ఆడియో మీకు వస్తుందా రావట్లేదా? ఏంది పోయిందిరా అది? అక్కడ డిస్కనెక్ట్ అయిందమ్మా వెబెక్స్. మీరు వీడియో వస్తుందా? శివరెడ్డి గారి కిందకి ఆడియో ఇమ్మను. నవ్ యూఆర్ గెటింగ్? నా హెడ్సెట్ ఆగిపోయిందిరా. జాయిన్ మీటింగ్ నొక్కరా. ఓకే 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 గెటింగ్. హలో రాఘవేంద్ర.
Hello, sir, can you hear me, sir, now?
Are you getting my voice?
Hello? Hello, sir.
రాఘవేంద్ర వాయిస్ వస్తుందా?
Audio వస్తుందా, sir? Can you hear me, sir, now?
ఏంటి వినపడుతుందా? వినిపిస్తుందా? రాఘవేంద్ర మీకు
ఇక్కడ నుంచి ఆడియో రావట్లేదు సార్.
నాకు చెవులోకి వస్తుంది. Can hear your voice, no problem.
Sir, can you hear me, sir, now?
Yes, I can hear. Just see, it's very contracted my side.
Sir, it is out of focus.
You're out of focus. Now,
A little bit down, sir. Down.
because there is a mismatch of what I am seeing, what you are seeing. Now you can see.
Little bit down. Okay.
Okay.
Okay. No, sir, little inferior, sir.
Because it's a focal length is down. Neuro microscope now it can't decrease more.
Sir, little bit zoom out, sir. Zoom out, sir, little bit.
This is totally lost zoom out.
Let's.
While going inside, I have to zoom more. Otherwise, next, my microscope will do.
How it will focus?
Okay. See, here's a small mastoid and also the sinus. Just release the famous part of the temporal bone. Okay. Nothing more important success present here. You can see the andro cell. It's already expected because no other case was there to do the live stream. That's why I was expecting this one. Not by 5. That's a great experience for all of you and also for me. With a small mastoid cavity, we have to do the complete the surgery. Having a canal wall, without damaging the canal wall and thinning out the canal wall, I'm trying to explore the thick part. Are you able to see the blue color wall of the sinus?
Yes, sir. Sinus and
This is the sinus wall.
yes.
This is the left ventricular canal what we are seeing there inside. I will go for a little bit magnification. Raghavendra. You are getting the lateral ventricular canal?
Sir, yes, sir. Visible, sir.
Okay, this is the bone. The part of the bone is called the corner septum, the junction between the ramus and the ramus part of the temporal bone.
Yes, sir.
And treated part of the temporal bone. Junctions, the presence of the remnant of the bone form as a corner septum. We have to reduce this corner septum to find out the incus. And also one small bony ridge after drilling the famous part of the temporal bone. We find a small ridge to protect the incus. That is called. There was no name for that. I want to keep my name for that. You can see this one. At the same time, I'm thinning the canal wall also. You can see, repeatedly I'm drilling. Always here, you have to come from medial to lateral because of the space issues.
So in between, it's better to point the structures, sir. Yes.
Quickly.
PGs and juniors are also right there for us, just.
See the tegment slate and also projection from the tegment. This is the corner septum, remnant of the corner septum. We have drilled out this one. Generally, we can find the incus, body of the incus. This is the lateral semicircular canal. We have to make the mastoid well drilling up to this level. Then only you can do the post-implant. We change the burr to the diamond burr. These are the important structures. Up to this point, we can do with the cutting burr. It's very small cavity, less than I think less than a centimeter, 1 centimeter, supra-inferiorly, anteroposteriorly, less than 1 centimeter. To the small area, we have to expose the post-tympanotomy. No problem for me. For the juniors, it's difficult. And also, there are no important structures. The mastoid cavity, the volume of the mastoid cavity, and the dimensions are all depends upon the position of the sigmoid sinus and the facial nerve. It defines the boundaries of the mastoid cavity and also volume. Here, we already find the one landmark, that is the sigmoid sinus. It was placed more anteriorly and laterally.
So centralize the pictures.
Excellent. Anteriorly and laterally it was placed. That's why it is restricting the surgical view. Now you can see. Okay.
Good.
This is the lateral semicircular canal. Just I am reducing the superior part of the segment and also the what I told the corner septum, like this. At the same time, I'm reducing the canal wall anteriorly. I'm trying to make the more space in the inferior part also. Then this is one position, one part of the microscope positioning. Then I will show the how to position the microscope. Now you have to turn the baby's head opposite side. In other conditions, all the workshops they will talk about the all sophisticated OT tables. Those are all not at all required. Only you can change the position of the head here and there. You can get the required angle. Here I have changed the position. I can able to see the body of incus.
Yes.
It was a reflection. We can get the reflection of it before reaching the incus. Also, this is the incus. This is the medial part. This is the horizontal part of the facial nerve inside. These are the first landmarks. This is the inguinal buttress. The boundaries of the posterior tympanotomy is the superiorly inguinal buttress, inferiorly caudofacial angle, anterolaterally chorda tympani, posteromedially the facial nerve. This is this triangular space we have to open to enter the middle ear space. Are you able to see the incus body?
So
Incus also? Okay. A little bit I will expose some more to the small size of the burr. If you have any doubts, just ask me in between because I am not that much professional to explain without asking anything. For my level best, I am doing.
So fine focus. Fine focus.
Fine focus. This is the zoom. Are you getting the fine focus now? Okay. This is the blood.
Sir, inside structures we are not able to focus.
Inside,
Yes, sir. Incus and
incus, see the incus head.
yes, focus it, sir. Fine focus in direction. Central analysis.
Focus. Okay, any other changes in the video? I don't know video output.
Sir,
Everything clear. Now we can see.
section line, sir.
Okay.
Yes, sir. Yes.
You are clear?
Clear, section.
This is the incus. You can see the mobility of the incus also. Okay.
Yes.
Based on that, we should not go with the line of facial nerve. We have to always anterior for that. The better way of identification is the post-implantomy. If you are able to identify the cardiac tympani, better to identify the cardiac tympani, follow it. Now I am seeing towards the helical part. Now I am changing the angle of the microscope in the mid side to see the post-implantomy area. Okay. See, some of the cells are visible here. The one more constant cell in the lateral canal wall, that is called the Herald cell. And later also, so many descriptions were given in the posterior wall of the middle ear. It contains the three eminences, 5 ridges, and 4 spaces. Those are all endoscopic descriptions. We can't see all those success microscopically. Here I'm making a small post-tympanotomy. Usually for a beginner, to see middle ear mesotympan and through the post-tympanotomy is better to expose wider. Because of the anatomical constraints, I'm opening very smaller one. Here the drilling is always, we have to keep in your mind, drilling always parallel to the vertical part of the vertical segment of the facial nerve. That is the masthead segment of the facial nerve. Masthead part of the facial nerve. Just I'm making a small thing. Here you go by layer, by drilling, you can get, you have to work your visual activity and also your ears also work properly, because the structure going beside the drill feature also will change. And also the texture of the sensation of the fingers also will change. Here I am doing very parallel to the facial nerve. Even though it is very much considered mastoid, I am going to the post-tympanotomy. Pardon? Centralized. I am getting small here. It's not clear for me also. These are the demo microscopes creating so much problem for me. Your eye is completely not visible properly. చిన్న dry gas pieces. కొంచెం మైక్రోస్కోప్ టెంపరేచర్ తగ్గించరా ఫాగ్ ఫామ్ అవుతుంది ఓకే we are getting the clear picture. Now I can explore once again anatomical orientation. Pick are you able to see this one? Lateral semicircular canal, incus. This is the area I'm making the post-tympanotomy. I'm opening the it's a very thick bone.
Sir, when you hear me, sir?
Okay.
Yes, sir. Just show us just one side.
Pardon? What do you want?
Drilling portion, sir,
Yes, I'm drilling here only based on the landmarks.
Just show the landmarks.
This is the fossa incudis, and also I'm not going posterior to the tip of the short fossa of the incus.
Sir, kindly do fine crossing, sir. It is deeper switches are not visible. This focus.
Here the fossa option only available. That's only. Yes, again I'm looking into the way into the middle ear.
Sir, tilt the microscope towards right side, sir. We can see the inferior.
Right side.
Right side, a little bit to the right.
Okay.
Right, sir, to your right.
Pardon?
Your right side, sir.
Yes, my right side will have.
Yes. Little bit down. Little bit down. Down.
Give the restricted view. I don't know why you are getting the restricted view. డ్రై కాదు సెంట్రల్ అని ఉందిరా కిందకనే ఉంది కిందకి లాగేసి మొత్తం లాగేసి ఇక్కడ క్లీన్ ఇక్కడ డ్రై ఇక్కడ మాత్రం అయిపోయింది అయిపోవట్లేదు ఫాగ్ అయిపోతుంది కొంచెం కూలింగ్ తగ్గించండి are you able to see that one? Now I am getting the cauda tympani anteriorly. Are you able to see that one?
So cauda.
Are you clear?
Yes, sir. We can see.
Am I clear to you?
The
focus is clear.
Now it is good, sir. Point.
Okay. I can show the cauda. Just this white mark you can see. That is the cauda. Okay. It goes anteriorly and medially. Based on the cauda, I am making a opening into the posterior tympanum water. Here we have to always very slow with the proper irrigation. Not only the physical trauma, also thermal injury also can cause the patient are vulnerable for thermal injury also. Small size. Then you have any doubt, can change the bar size also to enter the mesotympanum. I'm able to see the one cell exposed into the tympanum water. ఇది ఫాగ్ అయిపోతుంది ప్రతిసారి ఇది ఫాగ్ అయిపోతుంది ఫాగింగ్ హియర్ వదిలే చూద్దాం you can see the opening, small opening made in the posterior tympanum. You can see the fluid coming from this side to that side. You can see the fluid movement. Are you able to appreciate?
Yes, sir.
Okay.
Yes, sir.
Someone should respond. Are you able to appreciate?
Yes, sir. Yes, sir.
Okay. Based on this, you can enter freely, changing the size of the barbit. After entering the mesotympanum, we can widen it.
What is bar size bit you are now taking, sir?
Now taking to the 1 mm or 0.8.
Sir, what's your take on
Hot water.
Manoj sir's where he goes up to diagnostic bits, then comes down. I mean, comes here.
Pardon, I didn't hear. Pardon, comes again.
Sir, what is your take on Manoj sir's identification of posterior anatomy, where he goes first inferiorly, identify the niche, then facial nerve, then outer?
No, because usually I don't identify facial nerve. I can't find for the facial nerve. Usually this is the cauda tympani. Based on the posteriorly, I am exploring the cauda tympani. I am going to the mid here. There is no structure in between. Cauda tympani directly goes into the mesotympanum. No important structure present over there. Directly you can see the promontory now. You can see the promontory. Are you able to identify? Are you able to identify the promontory?
Yes, sir. Yes, sir.
Now, making on that, I will widen this superiorly, posteriorly, and inferiorly. This space is enough to do the AB, to insert the AB electrode. Just is not fitting my suction tip also. 18 number, 20 number, suction tip size. Then you can see the second landmark I am going to explore now. As a workshop to learn to teach you, I am exploring every the landmarks. As a routine, these are all not necessary, but it's always better to have the landmark. This is the second landmark to expose is the IS joint. If you remove this bone, here also medial to lateral. See, medial to lateral. Otherwise, you can dislocate the IS joint. You can see the superior tendon over here. Are you able to see the superior tendon? Anyone?
Yes, sir.
Okay. After reducing the posterior part of the bone to visualize the pyramid. What is the relation of the pyramid with the facial nerve? Sometimes we have to drill some part of the pyramid also to get exposure. Most of the times here the eyepiece is getting foggy. That's why I'm not getting the clear picture. Making it clear. Now it's clear for you. I can show the second hand one here.
Sir, illumination, anything you can increase, sir. Illumination.
Pardon?
Illumination, sir. Illumination. Lighting, sir. Illumination.
Illumination. Light ఆపేయండి. Now you can see the IS joint, stapedius tendon. Are you able to see that?
Sir, fine focusing, sir. Fine focusing.
Okay. Okay. Are you getting the picture properly?
Sir, it is being focused on the zygoma, sir. Can you focus on the material?
Zygoma. This is zygoma.
Zygoma and the technique is being focused as far as image. Focus on the material, sir. Literally.
Okay. Now you can see
Yes.
Yeah, I just okay.
this is a this is the tensor. Sorry, stapedius tendon, sir.
Okay,
The IS joint. This is the IS joint.
Yes.
This is the promontory. Now I can rotate the head in such a way to see the round window. See, just I'm rotating the head of the baby, and also the microscope to visualize the deeper part.
Okay.
I am able to see the round window niche.
Yes, sir.
You can see.
Okay. Are you able to see the round window niche? I will show the niche. Small section. This is the round window. The blue color. This is the round window. I will once. I will make some more opening there inferiorly to expose that total part. Here you have to take care of the not injure the facial nerve. Here also I am coming from. I am working on the medial part of the facial nerve. ముందు వేసుకోమ్మా అక్కడ. You can see here the medial side I am drilling. It's better in the right ear. Always use your left hand to drill. I'm using my left hand to drill the medial part of the facial nerve, the bone medial to the facial nerve, and also the caudofacial angle. I'm doing with my left hand.
Centralized.
Okay. Reducing some more bone over the facial.
Supply the picture, Rayudu. Please supply the picture.
Just a moment.
I'm not able to see completely.
My microscope is in different view you're giving there, sir. Here I'm showing exactly what I'm seeing.
I can understand, but yes.
No, it's okay, sir.
Okay, so our other people centers are able to see clearly and focus.
Now I can clearly see the promontory and round window.
I can see.
Small section. Thick. Next time we'll use the second microscope, sir.
Yeah, that's better.
See, round window niche. Are you able to see that one? I'm giving a small mucosal incision over the promontory.
Okay.
Why the mucosal incision? Here we can't use any kind of cautery to prevent the bleeding. Just, I will come to the later part. Here, some of the round window niche is covered by the false membrane. I'm removing the false membrane. Dry gel foam, please.
Okay.
Now you are getting the blue color shadow of the blue gray color round window membrane. True round window membrane. This is a false round window. Are you getting the point, sir? Now I'm getting the spine focus.
Sir, just a second, sir. Can you switch over to this endoscopic camera, sir? Endoscopic camera, sir.
Endoscopic camera.
If possible, sir, if possible, because
How to give that one also endoscopic camera?
endoscopic attachment is there, sir. Microscope.
This one, okay. Endoscope camera ఇవ్వండి. తీయమ్మా తీయమ్మా నొక్కి తీయమ్మా నొక్కు పైన ఇది కూడా ఎక్కడో చూపిస్తుంది. Okay. సరే దీని అవుట్పుట్ ఇవ్వండి రాటు బయటికి.
Now it's better.
Endoscopy, we are getting endoscopy camera. ఇది తీసేసి దీని అవుట్పుట్ దాంట్లోకి వెళ్ళమ్మా. We are trying to view the endoscopic output now. Okay, up to this point, it's all is okay. I have explored the round window. I have given the mucosal incision. Then I will come to the second part, decadal. Very narrow cavity. Adrenaline. I am closing this area with the adrenaline decadron gel foam. I will come to the lateral part of the drilling. X-ray camera. Sampurna. Cell phone on, cell phone. Mobile. File light on change number. Elevate. Top light on change number. Now, sir. Yeah, Siddhant is another camera, sir. In while we are switching on to the other camera. Hello, sir. Microscope focal length is variable, sir, very varying. That's why we are attaching the file. Now you can see the external picture, sir. Now you can see the external picture. Now this is the area where we have to make the receiver well. See the anatomy here also again. This is the squamous part of the temporal bone. It's also squamous part of the mastoid part of the temporal bone. It is also part of the squamous bone. In between, the parietal bone comes down like a U shape. The God has given the external creation. This is the flat area. Where the bone we have to make the receiver well is this flat surface. Always between the parietal protuberance and the occipital. This is the mastoid protuberance. In between, there is a bone is very flat. And also we can elevate this one with a previous elevator to accommodate the receiver well. See the template, silicon template. Based on the template, we have to make the receiver well. See, this is the bigger implant, AB, and also thinner. We have to make the markings over the bone. Here, to make the markings over the bone, better to have a pencil. It gives a good marking than any surgical pencils and all. Is a better way to create a mark. Are you able to see the mark? The pencil, the electrode array goes like this. Keep the retractor. మార్చారా ఇన్పుట్ తోటి దీనికి స్టోరేజ్ బిల్లు ఎక్కడ మార్చారు దీనికి దీన్ని ఇచ్చారా అది దీన్ని ఏమి ఇచ్చారు బయటికి నౌ యూ కెన్ సీ ద two prongs retractor. I'm applying another retractor over the Keithanes retractor to have the better view. it is always better to do with the microscope because of the quality of the zoom is more, focal length is more for the neuromicroscope. I am using with the external camera. Are you able to get in the picture? No, trust me. No. How to make a receiver well? I will show you in the simplest steps. Bigger. First, we have to make a marking with the burr bit, cutting burr bit. We have to make a gutter-like thing to know the thickness of the skull bone. This bone has a three. One is outer table, middle table, and inner table. Outer table and inner table. We have to make the drilling up to the inner table. In between a marrow content area is there. For that, we have to make a marking. Just I am making a marking of the on the bone. See, just I am making a marking of the just a gutter-like thing.
You have marked with this silicone implant, dummy implant, the borders.
Pardon?
For the belly, have you marked, I mean, did you mark sir with silicone implant and then?
Yes, I kept the silicone implant and make the marking with the pencil. These are the markings of the pencil markings. Okay? If you want, you can check gutter also in between the metal template. See the size, the same as I marked. Should you done the output right? ఆ కెమెరా మైక్రోస్కోప్ అవుట్పుట్ ఇవ్వండి బయటికి అది ఇచ్చారా వస్తుంది అరగంట ఓటీలో చేంజింగ్ అవుట్పుట్ just meanwhile I make the receiver that this is the only bone we work. We have to define the depth of the bone or thickness of the bone. After defining the thickness, we need to remove the in between the bone. We have to always have to take care of the underlying structures while breathing, the change of the birth and also the pressure over the bone. It will change us. See the thing. I made the required marking. Then I remove with the cutting. అది డిస్కనెక్ట్ చేస్తే ఆన్లైన్లో అడగదు అసలు దాన్ని పెట్టండి కూడా ఇన్పుట్ కూడా నాకు తెలియదు దాన్ని don't touch that one. If you touch that is unsterile. Don't touch it. You'll see that one. With the endoscopic output. వచ్చిందా Are you getting the microscopic picture now?
Yes, sir. I think it is attached to endoscope.
Endoscope camera. Okay?
Yes, sir. Now it is good.
అమ్మ కూలింగ్ తగ్గించాలి ఇక్కడంతా బాగా అయిపోతా ఉంది మైక్రోస్కోప్ చలి పుట్టిపోతుంది ఇక్కడ మైక్రోస్కోప్ అంతా ఫాగ్ అయిపోతుంది ఓకే Are you getting the picture clearly?
Yes, sir.
Are you clear?
Not clear.
Okay. Now I have made the template. Okay. Now you're getting the total picture.
But it is not centered.
Okay.
Please centered.
white balance. Camera white balance చేయండి. Camera white balance చేయండి. White balance. White balance. నువ్వు లేదండి. జూమ్ కాదు వైట్ లైట్ తగ్గించి వైట్ బ్యాలెన్స్ పట్టుకొని ఉంటారా? ఓకే, getting the picture in the proper manner. Lighting కూడా తగ్గించమ్మా, లైటింగ్ తగ్గించి లైటింగ్ తగ్గించు.
Please center the picture.
1 minute సార్, లైట్ తగ్గించమ్మా, తగ్గించు, లైట్ తగ్గించు, పెంచున్నావు. ఓకే సార్, you're getting the quality of picture now.
Picture is coming, but not centered.
I don't know what is the center. Here I'm getting the on the monitor also you're getting the clear picture, sir. Okay.
So zoom out a little bit.
Okay, sir. It's చాలా బాగుంది. నాకు ఫోన్ లో కూడా బాగా కనపడుతుంది. We are getting the good picture in the phone also. There's a problem with there only in the monitor. Here I'm getting the good picture. Otherwise, you can switch on to your mobile phones. We give the link. ఇది కాదు, బాగా cutting ఇది. It was centralized. You can see, check in your mobile phone also. సార్ పంపించండి WhatsApp లో లింక్. Okay. Just removing the outer table.
Okay. So yes, sir.
After defining the edge, nothing worry, just you can remove the bone. The mid layer is a marrow area. Sometimes it bleeds. You should not keep it in place. Burr always has to move, and also the one side of the burr only has to drill the bone, not all the sides. It's a very thin bone, is a dura. You see the dura, underlying dura. Without damaging the dura, moving the bone all around. In the situation, you can make a small depression. You can make out all the surrounding bone and make an island of bone over the dura. You hit the receiver well in the proper position. See the edges of this implant is fitting into the area. Now you can make the images more deeper by the diamond bar. Here I am making the round edges more 90 degrees angle to prevent the mobility of the implant. ఓకే, ఇక్కడ మన ప్రాబ్లం కాదు, ఈ మైక్రోస్కోప్ లోనే ప్రాబ్లం. No. Now we are getting the center picture, sir.
Sir.
You are getting the centralized picture.
Okay, sir. It's better, sir.
Because I'm working I'm seeing in somewhere, working in somewhere also. Because of this microscope problem, here I can see the direct vision in proper way, but it's projecting outside is a different. These are the demo microscope because there is some change in internal alignment while transportation. Maybe.
So it's possible
Later
to
side, okay.
it's possible to generalize.
I don't know what is your picture, viewing picture centralization. Myself, I am centralized. Now,
But
because I'm seeing lower one, I'm working in the upper part, upper quadrant one, I'm able to see. Okay, no problem for me. For your understanding, I can read it. Just I'm making just more vertical. Metal template. Some more thinning of the bone or the dura to the equal flat surface. Template. Again, you have to check. It's snugly fitting into the well. Then you have to make the electrode array out. Is the way the path of electrode array out. Here you can see the barbit, on tip of the barbit, how it's working parallel, almost on parallel to the bone. And also one surface is drilling the bone. You should not touch all the surfaces, it causes bubbling. And also jumping action will come for the burr. If you use the cutting burr, it's almost on parallel. You have to make this electrode array out.
drilling for not visible, sir.
Pardon?
Drilling for not visible.
I can't get you. Pardon. I'm making a electrode path for the electrode array out to come out from the receiver well. Template. Silicon template. Like this, the electrode array comes out like this. Are you able to see the silicon template?
Sir, electrode array not visible, sir. Electrode array.
This is the mastered emissary vein. Here you'll get the mastered emissary vein. Okay. Now you see the electrode array out.
Sir, just
Okay.
point.
This is the array out. From this point, we can make a node array. This is. The flap will comes like this. Based on this, I will make the electrode array into the mastered cavity into the post-implant. Small bit. Are you able to see the electrode array?
Sir, sir. Show the better, sir.
Is it clear? आपको clear గా ఉందా? ఇక్కడ రిఫ్రెష్ చేసుకోండి. Now you can see this is the sinus. Sinus comes like this. You have very lesser space. That's why I will take a small curvature making the for the electrode array to come out. Are you able to see that one?
Sir.
Centralization is okay. Now I'm making a small angulation.
Little of course. So now you are making another diagnostic to just to offer us.
Are you able to see the electrode area? I'm taking to the mastoid cavity. Now I'm using my left hand to go into the mastoid cavity. It having a small bony bridge, superiorly based bony bridge. Usually we have to come to the posterior part because it was occupied by the sinus. Now I'm using my left hand to come into the mastoid cavity. See how my barbit is entering, how it is entered. Are you able to appreciate my barbit? Tip of the barbit?
Out of focus.
Out of focus. Here is the focus. Okay.
So now, sir.
Okay.
Yes.
See the barbit, head of the barbit comes to the a small bridge made here only. I keep the bridge intact.
Out of focus.
I don't know where it's focused. This microscope is focusing where I am seeing. Now it's okay. Okay.
We are able to see the implant, sir, not the cavity gutter portion.
Now cavity.
Yes, sir. Now it is okay, sir.
Okay.
Yes, sir.
This is the path I made. This is the path I made. This is the bridge.
So you made a tunnel under the.
And I made a small intact bridge over here, and then go into the mastoid cavity. Now this this is the flap covering the implant. Then I do some soft tissue work. First, we have to cover the implant anyhow with the two layers. One is the musculoperiaxial layer, one is the skin. Here we got the proper musculoperiaxial covering.
Now you are focusing tissue, sir.
I am making a proper
Focus. Elevating the flaps underneath.
flap. Knife. I'll take a small soft tissue to see the electrode array and fixation of the implant in the posterior tympanum and also the round window, around the round window. Now we'll change to the. We have to see how to show that one. With the microscope, huh? Okay, we'll shift the microscope, then we'll get the clear picture, maybe. Huh? Okay. Adit Lal. We are shifting the microscope. And fix it. Maga.
Zero, sir. Zero.
And are you getting the clear picture? I am not getting the clear picture. Dry gas species in this. Retractor. Table height check కొంచెం. నెంబర్ 1 క్లియర్గా లేదు. నా క్లియర్గా లేదు. నాకు అసలు క్లియర్గా లేదు. ఒకసారి గ్రాస్ స్పీసీస్ లేదు. నీళ్ళు పడతాయి మళ్ళీ ఎక్కడి నుంచి. ఓకే. Okay, now it's clear for you. Hello.
Sir.
Are you getting the anatomical picture now properly?
Sir, 5,000 units. 5,000.
Okay. You're getting the total picture? నేను చేస్తాను. Maximum. It is the only adjustable focus. క్లియర్గా పెట్టి నేను అడ్జస్ట్ చేసుకోవాలంటే is it clear for you? Is it clear, Raghavendra, for you?
Sir, they are unable to see this round window items.
Unable to see that?
Focusing.
Okay. Now you can see the carda stapedius muscle. Retractor.
Sir, centralize the picture, sir. Yes.
Retractor. Now you can see the picture now. Yes. No touches, no touches, hand touches, no touches. Gloves march. Now you can see the picture on the monitor. We clearly see the picture well.
Now it is good, sir.
Okay. You're getting the promontory view. Promontory.
Promontory is visible.
Or retractor, a small section.
Not there in the center, sir.
Not in the center. Yes, sir. Now,
So, okay, sir, we are able to see the promontory. Gel form of
promontory, I'm removing the gel foam.
yes.
అంతలాగా మాకమ్మ. Now I'm rotating the head of the patient
Yes, sir. Able to see the round indentation.
around the Nishna. Just that little bit. Sorry. No, retract it. Back side retract it. Okay, now you're able to see the round window niche.
Sir.
Okay. Are you able to see the round window niche?
Yes, sir. So now it is out of focus.
Okay. Okay, you can see the blue color.
Yes, sir.
We are able to see clearly here on the monitor also.
Now it is clear, sir.
This is the round window niche. Okay. I'm working over wider 0.8. We have to explore the 360 degree of round window membrane by removing the overhang. I'm using my left hand to remove the bony overhang of the round window niche and also anterior lip. After removing the anterior lip and bony overhang only, we can able to see the speed the gichara. We can see the round. Yeah, ఏం ప్రోగ్రామ్ ఉంది 1:20:1 లో ఉంది 1:1 పెట్టి 1:1 1:1 నొక్కు మళ్ళా ఉంచు అక్కడికి వెళ్ళి తగ్గి స్పీడ్ ఇప్పుడు స్పీడ్ మంది కాదురా ఇది 1:1 పెట్టు స్పీడ్ తగ్గించు మైనస్ ప్రోగ్రామ్ కాదురా స్పీడ్ తగ్గించమంటుంది నిన్ను నీ మెంటల్ స్పీడ్ రా రెండో పద్ధతి అరే నేను ఆగు తగ్గించు తగ్గించు రిట్రాక్ట్ చేసుకో కొంచెం రిట్రాక్ట్ Are you able to see the round window? Just with my left hand, I'm drilling the superior bony overhang. We explore the more. Are you able to see the round window properly?
Yes.
I'm anterior lip and also superior bony overhang. I'm removing. To have the proper trajectory, the electrode has to pass inside easily without having any difficulty. To get the trajectory, we have to pass from posterior superior to antero-inferiorly. The making the path for the electrode. Now you can see the total round window. I'm able to see the total round window. Okay. Are you getting the picture or not?
Yes, sir. It is just, I think, color of the blood is.
Okay, is a round window. Are you able to see that one? The entire round window I have made delineated. See, I'm showing with the pic. Are you able to see this one? Raghavendra.
So now there is a center picture, not as a center.
Now you can see glass pieces. Clear until then. You're getting the good picture now? Huh?
Yes, sir.
Is centralized or not?
Fix it. Now it is good. Now it is good.
Okay, you can see the membrane visible inside and also the blood vessels over the membrane. Are you getting the good picture or not?
Yeah. Yes.
Yes, sir.
This is the exposure of the round window. It finishes the total work. Just we have to insert the electrode. That's all. If you want, I can remove the small bony overhang there, which the posterior wall of posterior implanted posterior wall and also over the facial nerve. I am reducing somehow water కొంచెం sucking పెద్దది కొంచెం. Are you able to see all the landmarks in a glance? This is the body of incus, lateral semicircular canal, facial nerve, that is the stapedius tendon, incustostapedial joint, కొంచెం పెంచరా స్పీడ్ అట్లా ఉంచు ఇట్లా ఉంచు 10,000. Now I'm reducing the bone over the facial. Okay, now you're able to see the round window.
Yes.
కొంచెం పెంచరా స్పీడ్ 1000 కాదు 10,000 చేయమన్నాను.
Now we are already implanting
I'm increasing the space posteriorly to visualize the round window for you. I'm able to see better for your understanding. You can see now. Okay. Pick. You can see the total round window. Record on Adeline. This is the sinus, lateral sinus, most anteriorly and laterally placed sinus here. Adeline. Now we are changing the gloves. We have to switch on the cautery. Before switch on the cautery, we have to verify the any bleeding points. We have to verify the bleeding points all over the areas. And also the flap is properly covered or not. We have to verify everything. Bleeding ఉన్నట్టుంది ఇక్కడ. ఒక నిమిషం ఆగమ్మా. ఉంచు ఒక నిమిషం. బ్లీడింగ్ పాయింట్ ఏమిటో చూడు, బ్లీడ్ అవుతుంది. ఫైల్ అయితే ఆన్ చేయి. Hmm? You have to all the bleeding points. Wash. We have to give a proper wash to remove the bony dust and external canal. No. We have to change the gloves. Surgeon and all the assistants who is assisting, we have to change to the new gloves before taking out the implant. With the utmost caution while taking out the box. Before box also, some of the companies will do test intra-box testing, so it's available. We have to take like this. We have to lock with the artery forceps. Then only we have to peel off the outer cover. Implant will be like this. We have to peel off the outer cover, and also to relieve the static current electricity, we have to immerse the implant with the saline. After taking out, it also is fixed to the case. It won't come out easily. We have to take with the hand. We have to transfer the implant, taking like this, and also the electrode in between the ring and little finger. And like this, we have to transfer the implant to the site of implantation. Here, for the sake of documentation, we have to take the picture of the implant with the serial number. We have reduced to the lower version. Are you able to see the implant serial number?
Yeah. We're able to see.
Okay. It was present underside of the implant in AB. All the implants having the superior surface. With the under surface, you have the serial number. That's why you have to take the picture. Then we have to change the direction. We have to keep like this. We have to insert below the musculoperiosteal flap. Sometimes we may get into the false passage in the subcutaneous area. We should not keep in the subcutaneous area in the musculoperiosteal flap, under the musculoperiosteal flap, and also it has to cover the entire implant. See that one. I kept there. I didn't open the round window niche till now. After keeping the electrodes and everything ready, then only we have to make opening of the round window membrane to insert the electrode glass piece with the drill.
Which company? Which company?
Pardon?
Which company think that?
These are advanced bionics. Each and every company has a different designs of implants.
How many electrodes is this?
How many electrodes? Audio 16.
16 or 16?
16. It has 16 electrodes. Some of the companies have 22. Some of the companies have 12 to 24. Like that. These audio advanced bionics having the 16 electrodes. 16 electrode channels. Now I'm exposing again the round window, retract remark, anterior. Suction, cinema, Saraga. Suction. Getting through that mark. కొంచెం పెద్దది in the very narrow mastoid cavity, you can see in the web or textbooks also. The mastoid cavities are very wide. Here I want to stress one point. This physiologically functioning masthead. There is no disease at all in the masthead cavity. That's why we need not to explore the synovial angle tegment. We have to make out the tegment. Just the path has to be created to enter the electrode array from the receiver well to the masthead cavity into the round window niche, into the entry to the cochlea. That is our main aim. Surgery cell, పెద్ద piece తీసుకో. చెప్పింది విను. డ్రై జెల్ ఫోమ్ తీసుకో. వద్దులే. We have to make the path of the electrode array into the cochlea. The scala vestibuli. Why we are keeping in the scala vestibuli? The scala vestibuli is the wider one, and also it contains the basilar membrane. Inferior surface of the basilar membrane projects into the scala vestibuli. Sorry, scala tympani. Tympani, sorry.
Not scalar, but
Scala tympani. We have to keep the scala tympani. Are you able to see the round window niche?
yeah, we're able to see.
Just I am make a opening antero-inferiorly on the round window membrane. Just I am make a opening in the antero-inferior part. Just see the fluid of the perilymph is coming out. Nothing more I am doing here. With the lower magnification only, I am taking out this electrode out. Jewel forceps. Jewel forceps. I am keeping into the under the bridge. I am taking out from the bridge the electrode. Now I am taking the special forceps to electrode, introduce the electrode. That is the AB forceps. Here AB has given a flange like silicon block to hold the electrode. I am taking with my left hand suction. Just holding the electrode with my left hand. I am making the entry of this tip. It has a curve. Small suction gani. ఇది కానీ ఏంటది and making it fast.
Slightly focus,
అసలు నాకు ఏం ఫోకస్ లేదు సార్, నేను ఏదో పని చేస్తాను. ఓకే కళ జస్ట్ వీ హ్యావ్ టు మేక్ ద పార్ట్ ఆఫ్ ది, ఇది కాదు ఆయన మామూలు కళ ఇచ్చిన బాగుంటుంది. మన కళ ఇది బాబు, ఏదో కళ ఏంటి because of different lighting conditions, I am able to see this one. నాకు మైక్రోస్కోపిక్ లైట్ చూసి చూస్తే you can hold like this, then suction ఏదన్నా ఏం అవసరం లేదు. We're holding like this, just I'm introducing into the, it's going easily on its own. Just, are you see, I'm at the entrance of the round window. I change it to the higher magnification. Are you able to see it? Are you able to see it or not? Going easily, smoothly, without having any tension. The microscope head also moving on its own. Suction. I have taken some time to introduce into the scala tympani to accommodate itself and also to displace the peroneal powder. It's come out. Because of the movement, swing action, it comes out easily. No problem, we can introduce it. It's going. Okay. See, all of you see it.
Yes.
You have to stop it here because I have changed into the higher magnification for your better visualization. It's gone totally inside. See, okay?
Yes.
Now lower magnification. Okay, now you're able to see it on depositor. We have to seal the electrode there itself. It's snugly hugging. The blue mark will be there. It's gone inside the round window. And again, all around we have to seal it with the soft tissue seal. All around we have to keep it. ఏం శ్రీనివాస్ మామూలు పడుకుని ఇక్కడ ఇబ్బంది పడుకున్నాను Surgery, sir. Surgery, sir. Are you able to see the posterior tympanotomy opening? What I am doing there, it comes out again. Otherwise, you won't fix it properly. Soft tissue. All around the implant, we have to seal with the soft tissue and also the surgery cell. We came to the lower magnification again. Surgery cell. Surgery cell. We have to seal all around the electrode. This is called the fixation of the electrode. Surgery cell. Where is it? We can fix the posterior tympanotomy. I have fixed the electrode, and we have to keep the dual forces. We have to keep the extra length electrode in the mastoid antrum, not in the. You can use this limb to go like this, medial to the fossa, body of the incus.
Yes.
Are you able to appreciate this one?
Yes, clear.
It's clear? Okay. It has to go medial to the, see that one. You can push this area and also large. Okay, it's gone and seated over there. For this, we have to make the bony overhangs, not the smooth edges like routine temporal bone dissection. This is పెద్దది. నిలబడి చూస్తారు. We have to lock this also here with the surgery cell. So everything fixed. Okay. Then this is see the electrode area out coming from this canal going inside soft tissue. Receiver coil. Here I'm also keeping the soft tissue harvested to protect the electrode area coming out from the implant. This will check the integrity of the implant. Excel camera. Coil. Oi, what are you doing now? Okay, we'll keep the surgery cell all around. Time ఎంత అయింది? Wireless? Okay, give me the phone. Some sterile part, how can you touch there? Glove in the glove thing. You keep a glove. Could not. Sterilium. How can you use like this? Sterilium. What happened to the routine cables? Better than this. So tell me, bro. I'll go to gloves only. Keep it inside that one. Keep it inside. Total part. Okay. Then gloves marks. Put it again. Okay. Okay. Okay, attach. Gloves and one. You can see the telemetry they are doing. Here, new technology are using the wireless connectivity. Usually, you can attach with the cable. They are doing wirelessly. You can see on the external camera. Are you able to see the external camera? Telemetry.
No, sir.
Okay. Impedance, okay. Okay. The impedance is very good.
Sir, external camera not visible.
His camera is
ఇది సజెషన్ ఇచ్చి డిపాజిట్ సజెషన్ పొడవాటి
Sahasra, I will start NRI.
Meanwhile, I keeping the suggestion all around the receiver well to prevent the mobility. It is exactly fitted. There is no space at all to move the implant. There is no space at all, even though for further protection. Why? Because I am not using any kind of fixations. Either suture to the bone drills, bone holes, also the any sutures, rolling or bond sutures. I have not applied. Why? Because I made the exactly fitting cavity for the receiver where it won't cause any movement of the implant. That's why I'm using the suggestion to cover proper way, and also tissue over that gel foam. Yes, stitched in the button created for the electrode area out, and we have to keep the suggestion. I'm keeping the suggestion over the sinus exposed here. Gel foam. I'm keeping the gel foam in the cavity to prevent the accidental suturing of the electrodes in the skin. Sometimes you will mistakenly keep the bite of the electrode. That's why I'm keeping this one. After that, I will close the sutures. First, we have to close the. Okay, it's getting good response. All are good. Now I'm closing. See, the closure has to start from the inferior part. I'm using the microscope for the closure of the wound for your appreciation. First, take the bite always in the inferior pole, then the posterior, then the anterior. Seen loss. నాకు కనపట్లేదు చేయొద్దు వస్తుంది. Just I'm fixing the inferior part of the lab. Without tension, we have to close it. అరే పంపు ఆ కెమెరా తీసుకో. కట్ తీసుకో ఏసీ ఆన్ చేయండి పెద్దగా. Now I'm closing the flap in a proper manner. Here, what are the issues with the microscopes are the first microscope had a longer focal length, that is the neuro microscope, and also easily optics are easily foggy. And also you're getting the different picture of what I am seeing here is different from you. That's why we have changed the second one. Second one also having the lower quality. And also we have used the endoscope picture. Any doubts? Now you can answer the doubts. Anything. Just I'm closing it down. Here we have to strictly close with the two layers. Already have explained here. To prevent the extrusion of the implant out, we have to cover with muscular periods and skin flaps. We have already made in a proper way to cover the implant. You should see how easy the implantation. Did you felt any difficult areas? Because of the equipment only, we have taken a much smaller extra time. Otherwise, it will complete within an hour. Just like a myeloplasty, there are no much problematic structures in between while drilling. Only the thing is here obstructing is the sigmoid sinus. We have encountered the anterior and laterally placed sigmoid sinus. That's why we made the small mastoid cavity. Through that only we have made the very small post-operative opening to enter in the middle ear. There we can explore the round window easily. By following the landmarks, we can't harm anything inside. And also, we didn't use any kind of special equipment, any skeeter drill or the facial monitor. With only the equipment required for the mastectomy and to the cochlear implant is the same. Only few are the special instruments is like a claw and these are given by the surgical companies. The implant companies will supply those special equipments required for implantation. Remaining everything available in our routine OT. And also you should have the good microscope. The beginner should have the good microscope to have the depth perception to make the drilling over the round window niche. And also one more difference is now we have seen this technique is the post-implantomy. 80 to 70 to 80% of the people using this technique. Next, we are going to demonstrate the area. Though both techniques have the merits and demerits, but the surgeons are divided into two procedures. But I'm able to do the both techniques in a simple way. That's why I'm demonstrating this. This may be the first time in India one surgeon demonstrating both techniques. Here I'm covering the entire implant with the muscular periosteal flaps. Then the skin suture. Skin suture also I will put with the subcuticular sutures to prevent the big scars over the skin. These are the small children. If you make a 5 to 10 minutes of time to give the good scar for his lifetime scar.
Okay.
I'm using the anterior part. Now I'm anterior part. And also you remember that I have made another anterior based flap to cover the area gap. Sometimes it may not cover the entirely. That's why I have made this one. I switch it later.
Any questions to be asked, please ask right now. Coming at the end of
In the area, the drilling part is some more different from the post-implant anatomy.
Okay.
In the area, there is a more soft tissue work. In post-implant anatomy, more of bone work.
Okay, okay.
But there, what they're selling, they're dealing with the squamous part of the temporal bone. No other bone is drilled by in the area technique.
Okay, okay.
Because we're entering to the mesotympanum through the squamous part of the temporal bone, making a small transcanal drilling tunnel-like thing with a special perforator. The Stefan perforator is available. That also a blind procedure.
Okay.
We can't see what drilling inside. We have to come from the 11 o'clock position to the 9 or 10 o'clock position to the mesotympanum, parallel to the incus, medial to the quadra tympani. We have to make a opening.
Okay.
And also one advantage is there we have to elevate the tympanic membrane totally. We will get the panoramic view of the middle view and also round window, promontory, everything we can see through the exploratory canal. Routine ear surgeries while we are working as a laryngoplasty and arthroplasty, we can explore the total middle ear. Like that, in the area, we can see the total middle ear. There is a major difference. Those having the fear of damaging the facial nerve, they are opting for the not only that one, and also the more anatomically sophisticated. The Dr. Hans will describe everything. Embryologically, we are not damaging the normal structures. Why to open the mastoid? There is a big debate about these both procedures. I don't want to go in detail to the deep issues and also the controversies. There are two procedures are there. Choice of the surgeon, they can adapt whatever the good one. Both has merits and demerits. Usually, just I have experienced the. Meanwhile, I want to tell some of the things happened in the during cochlear surgery. I'm practicing as my ENT surgeries. I'm not at all interested in the cochlear surgeries initial days. At the time, one my audiologist came and seen my ENT ear surgeries, micro surgeries. He advised me, "You're doing better mastoid surgery, sir. Why don't you do cochlear implantation?" To do the cochlear implantation at the time in RQ3 program, we have to have the 50 beds and also equipment cost around more than 1 crore. I'm a small practitioner. I don't have that much kind of amount. That's why I'm not at all interested to take the cochlear implantation and RQ3. The times are going like that. He insisted me to go for the cochlear implantation workshop. In 2011, I have gone to the live surgical workshop conducted by Dr. Hans in Delhi. There I have experienced the various technique. From 2011 onwards, after seeing the surgery, I am also not inclined to the surgical to get the approval for the Arigistry because of the financial problems. Just going like that way. After that, in 2015, we had an opportunity. I have tried all the specialty hospitals and multi-specialty hospitals in Guntur. No one allowed me to do the cochlear implantation in their hospitals. The only question is you are very new. I think you don't know how to do the procedure. How can we give the opportunity to do in our hospitals? You may get the bad name. That was it was very disheartening to me. That was I also keep quiet for some days. I didn't approach anyone. Later on, we found one of the charity hospital there, St. Joseph's Hospital. One is a Christian-based hospital. They are ready to support me for Chief Minister Relief Fund patients. With the much difficulty and great efforts by our audiologist, we got the approval from the Apollo team to help us to start the cochlear implantation. In 2016, March 3rd, we did the first cochlear implant in St. Joseph's Hospital. There we are getting all the CMR patients only. We are doing. While doing some sort of issues has arisen, the program was totally stopped in between. I'm helpless. No one is there to help me at that time. I struggled a lot to learn myself. And also we have the patients, no one to support us. And in 2017, I think 18, Dr. Shobhan Babu has come down to my hospital and he teaches me the surgeries. We have posted the 3 surgeries on the day. The first surgery he demonstrated me in a kind manner. And second surgery, second half of we did. Third surgery, I did myself. From the day onwards, I didn't require any of the surgical assistance. I learned all the techniques in my own way. like that is going on. From 2018 to 2022, I have completed 500 implants. And also, I'm operating in 16 centers. 16 centers. And also, I have used all types of implants, all types of electrodes. And also, one proud thing is, I have mentored for all the 3 companies available in the market. This is about my journey, because why I'm telling all these things is, don't worry about the implants, equipment and all. The only thing is how to develop the interest to do the cochlear implantation. The only thing required is the getting the patient, also the good microscope and good anatomical exposure of the mastoid. Here on the web, why we have called for the physical meeting here is to see the from A to Z of the cochlear implantation. On the web, you only get the surgical steps, how to prepare the patient, how to make the position. If you proper positioning only, you can able to explore the round window. Otherwise, round window you unable to see it, because round window placed posteriorly to the promontory. Posterior part is a very smaller one. The dimensions are 2 to 3 mm and 1 mm, 1 to 0.5 mm. The small area. To identify the round window, we should explore the master in a proper way with the step by step and the landmarks. Already I have shown the landmarks. The first landmark is the, we have to expose the mastoid cortex from the tegment tympani to the tip of the mastoid. Then we have to drill the outer cortex, that is the squamous temporal bone. There you have to find out the mastoid antrum. That is the most consistent air cell in the mastoid cavity, present in all the bones. After identifying the mastoid antrum, you have to follow hiatus antrum. You have to drill the part of the bone. That also squamous part of the temporal bone. No more important structure present in the squamous part of the temporal bone. We have to reduce the bone to find out the incus, body of the incus. The first reflection of the incus comes on the water. Then we have to remove the bony hang over the body of the incus. Then we have to for the fossa incudis. The small bone of the horizontal buttress largest the fossa incudis. Then you have to explore the posterior limit of drilling and also depth of the drilling by the lateral semicircular canal, depth of the lateral semicircular canal.
Yeah.
After that, you have to up to the mastoid tip, you have to thin the posterior canal wall, bony canal wall as thin as possible. Then you can find out the other landmarks to go into the posterior tympanum by drilling in the posterior tympanotomy. Where the landmarks are anteriorly, it is better to have always to find out the cardia tympani instead of facial nerve posteriorly. If you damage the cardia tympani also won't happen, but it is better to damage the cardia tympani in bilateral, because the tail may lose the other special sensation of the case. That's why you have to take care of the preserve the cardia tympani. Placing on the cardia tympani, you have to drill inferiorly, posteriorly to the cardia tympani. You have to enter into the posterior tympanum. Then you can find the different kinds of cells over there, different ridges and different valences. If you see the fluid movement from the small opening of the posterior tympanotomy into the aortic, then you have to make the bigger one, that one. And also the creation of the visual axis is the main step to see the round window. The axis. Why? Because we are seeing a small constricted area of opening posterior tympanotomy. See the suture I have made, and also I have given the subcuticular sutures. You can't see the scar afterwards.
You are not able to see the picture. Small.
Okay, Adi. You see the picture, sir?
I'm not able to see the small box. Okay, it's okay.
1 minute, sir. Mhm. కట్ చేయి మొత్తం కట్ చేయి సరిపోతుందా వస్తుందా you can see the picture now. Okay, how the suture line. This is the suture, small 4 cm, less than 4 centimeter suture, large suture, 4 cm. It completes the surgical part. Then we have to apply the Other bandage with an anesthetic helps. In the gas piece. Fine light. I'm very sorry for the quality of video. Those are all not in my hands because of the available resources, minimal available resources only we are able to positive the workshop. With the experience of this thing, we can improve next time. And also daily we are doing with our center. Anybody interested, they can come and observe in my center.
After this case is over,
I think we can take the lunch break after the surgery to prepare the second case with the same Microsoft we have to use for the area wedding. Anyone having the doubts can ask freely. Doubt is a doubt. It is a simpler or there is no quantification of the doubt and also quality of the doubt. You can ask anything here.